from here and there, just so people who will be testifying have an idea who we are. So I'm Glenn Martin. I'm chair of this subcommittee of the Behavioral Health Services Advisory Council. Ralph?
Ralph Pisano, a member of the Project Review Committee.
Rochester?
John Lee, member of Project Review Committee.
Hello,
we have a great gang here this time. Usually it's me and one or two other people, but we got a crowd. We got to find a bigger room.
I'm looking for balloons and trees and parties.
Yeah.
It's the holiday party, right?
Yeah.
After
oh, yeah. Oh, yeah. The commissioners will be in wearing little elf hats later. All right, and Albany, I'm sorry, who's there?
Susan Wheeler.
And Bill
Susan.
And Bill Getman.
Okay then. All right. So I'm almost. Which agency wants to go first?
Right. Oasis can go first. We have the least amount.
Yeah, but numbers aren't everything.
As always, it's at the chair's discretion.
Yes.
Yeah. All right. Well, I'm stalling for time here. I think I actually have a computer that will allow me to open things up. Oh, Lord.
You don't want to... Do you want to use this?
No, it's on. Do you like that view better or this view? Or it's just the sound? I'm going to try that.
Turn it
I can turn that more. Nothing's being said.
So Oasis is going to go first?
Yep.
All right, so yay! All right, so I see there are, 4 projects on the agenda?
Correct.
All right, first up is Brooks Memorial Hospital. Is there, just so for time, is there anyone in the room or elsewhere who plans on testifying about Brooks Memorial Hospital?
I'm here for questions.
There's someone in Rochester, yes.
If there are questions. Oh, there are many questions, but are they germane?
And Dr. Martin, I just want to say we have legal counsel for the applicant here in Albany as well.
All righty. So we got the lawyer, we got the whatever operator, owner, representative. Okay, so who's going to present what?
Might as well just do it now.
Okay. You want me to do it or you want to do it? All right. Since this is a project that has 2 applications, one on the OMH side, one on the Oasis side, I'll just give the quick overview. And then as the committee has done in the past, it will require 2 votes, one for the OMH project, one for the Oasis project. So we have OMH application number MHA 2790 and Oasis project number 2017.093, Brooks Memorial Hospital. The applicant is requesting approval to become the sponsor of TLC Health Network in preparation of a merger of the 2 entities. TLC Health Network currently operates an OMH licensed 20-bed psychiatric inpatient unit for adults at the Lakeshore Hospital campus in Chautauqua County, and Oasis programs in Chautauqua and Erie counties. The current sponsor and operator of TLC Health Network filed for Chapter 11 bankruptcy, and as part of the restructuring of the organization will merge with Brooks Memorial Hospital and no longer exist as a separate entity. To ensure future medical services in the area and reduce the overall operating expenses of the hospital, the applicant proposes to take over the sponsorship role of the hospital. The currently licensed entity will continue to provide the operational services of the facility. Once the merger is completed, it is the intent of the applicant to become the licensed operator of the hospital as well. With the next closest facility being 38 miles away from this location, the next closest facility is 38 miles away from this location, and this is the main provider of services for the surrounding areas. Brooks Memorial Hospital is currently in good standing with all New York State's licensing agencies, and there is no changes in services or capacity anticipated as a result of this proposal. Both OMH and Oasis are recommending approval.
Did you want to add anything, Gail?
Okay, this is Gail Keeler for Oasis. We do have Keith covered pretty much everything from our side as well. We do have 2 contingencies. We'll need a filing receipt from the Department of State for the addition of our language to Brooks' Certificate of Incorporation. and then final approval from the Department of Health.
Okay. Was this on the civic agenda for the second?
Yes, it's already been approved.
It is, yeah.
It's already been approved,
Okay.
yeah.
Okay, yeah, no, it sounded familiar. All right. So it's going to remain Brooks, the name, after all of this?
Mayor, you want to, the name is going to change to Brooks TLC, so the name will change upon the merger.
All right. But the sisters will not be forgotten.
It will not be, sir.
Good. Now, I frankly one of those people who gets annoyed that you throw an extra $50 million someplace and your name goes on the building. Crossing out the person who had given more a decade or so before. All right. So does anyone, talking about germane comments, does anyone have any to make? Any questions? All right, any questions from council members or committee members?
No.
No.
All right. Any discussion? If not, the first order of business, then, since we started with Oasis, will be to approve the merger for 2017093 of Brooks and TLC. Any further discussion? Seeing none, we'll vote. All those in favor, please say aye and raise a hand.
Aye.
Aye. Anyone abstaining or saying no? Okay, so that passes. We'll give an affirmative recommendation when we meet later today. And from the OMH point of view, same motion. Any discussion or concerns? Again, seeing none, we can vote. All those in favor, please wave or say something so I can see you.
Aye.
Aye. All right. Anyone saying no or refusing to say anything? All right. So that passes. Yay. All right. We'll move on. Gail, you're going to tell us about Mental Health America of Dutchess County.
Yes, they are requesting
All right.
OASIS approval to become the sponsor of OASIS certified programs that are currently operated by Mid-Hudson Addiction Recovery Centers, Inc. Mark will remain as operator. Adding Mental Health America as sponsor will allow for consolidation of various aspects of the organization, including healthcare coverage, billing, electronic health records. They do intend to complete a full merger probably in about 2 years. There will be no changes to any of the currently certified services, so need is not relevant. Dutchess County Department of Behavioral and Community Health recommended approval, as did our Mid-Hudson field office. Mental Health America of Dutchess County was established as a domestic not-for-profit corporation in 1954. And their mission is to ensure that clients have access to a full spectrum of mental health services. They submitted Appendix 4 character and competence applicant review, as well as governing authority questionnaires for all board members, and there were no concerns noted in those documents. They have submitted an amended and restated certificate of incorporation and bylaws for both entities, which our council's office is currently reviewing, and we will need our council's office approval of those prior to issuing final approval. Mid-Hudson Addiction Recovery Centers has been certified by OASIS since at least 1996. They currently provide services at 5 locations. One is newly established within the last year. The other 4 are currently operating in good standing with OASIS. There will be a new board formed of 14 existing members from the Mental Health America board and 6 members from the current Mid-Hudson board, which will provide the necessary chemical dependence experience. No changes to the staffing, the policies and procedures, the services, the budgets, anything. As I said, Mark will remain as operator. Both entities are fiscally viable. State environmental quality reviews were completed for all the sites, but no additional facility information requested because there will be no changes. And our recommendation is to approve Mental Health America of Dutchess County, Inc. to become a sponsor of the MARC programs with a couple contingencies: our council's office approval of the entity documents, filing receipt from the Department of State for the addition of our language to MHA's Certificate of Incorporation. And they also need to revise a board resolution and board meeting minutes. They inadvertently had mixed up the relationship between the two entities, but they have confirmed that it was presented properly to the board and voted on properly. They just need to fix the actual documentation.
So it reflects that MHA is taking over Mark, not the other way around?
It had to do with one of them being identified as the sole corporate member of the other, and I don't remember offhand which was which, but the way they had it documented was backwards. But they
Okay.
confirmed that it was presented correctly.
All right, cool. So the Mark units, they're all certified for either 2 or 3 years and they're in good standing, and MHA is the same?
MHA is not currently certified by us, but they got
Right.
very high recommendation from Dutchess County and the field office. And they are an established mental health
Yep.
provider, yeah.
Okay. All right. Is there any, well, did anyone sign up to testify? I doubt.
We do have a representative here, and
For questions?
one in New York City too, I believe, if necessary.
Oh, yeah, but for questions only?
Yep.
Yeah.
Okay. All right. So does anyone from the council or the committee have any questions?
No change in service offering or,
No, Mark's gonna remain as the operator and continue to operate the services.
good, thank you.
Okay. Any further questions? All right, so the motion on the table will be to approve the merger. Any further discussion? Seeing none, we'll vote. Committee members only, obviously. All those in favor, please say aye and wave.
Aye.
Anyone opposed? Anyone abstaining? All right, that looks unanimous, and we will report that to the committee later today. We move on to the third applicant. Just give me a moment. This is a capital project this time?
Correct.
Money. Okay, do you want to present, please?
Alrighty. So this is a capital project in the amount of $6,270,000 for Alcoholism and Substance Abuse Council of Schenectady County, DBA New Choices Recovery Center. The application is for the acquisition of a new facility at 724 State Street in Schenectady. It'll house New Choices, chemical dependence outpatient services, and administrative offices for the providers' housing and other OASIS certified programs. For the past 10 years, New Choices has been actively working to identify a more suitable facility. As currently their programs and administrative offices are located at 302 State Street in Schenectady in a 120-year-old former Masonic lodge. And given the aged structure, infrastructure, and problematic internal configuration, the facility is not working out. Maintaining the facility and its utilities, including plumbing, electrical, and HVAC, in safe working order has been an ongoing issue. And due to the age and size, renovating this building would cost an estimated over $10 million. Efforts to find a suitable property have been difficult for a variety of reasons, including access to public transportation and zoning issues. The 724 State Street site, located approximately 1.5 mile from their current location, has become an opportunity to successfully relocate. It meets the transportation needs of the clients, as it's on a main bus route, and remains in close proximity to the community residents, which many of the clients reside. The property is being offered for sale as a built-to-suit turnkey facility by Highbridge Development, LLC. An independent appraisal and feasibility study conducted by the Dormitory Authority of the State of New York, DASNY, determined the value of the finished property to be $5,900,000. The total proposed project costs for this 22,400 square foot facility are $6,270,000, which includes furnishings and other soft costs. New Choices has been in existence since 1968 and has developed expertise in serving individuals with multiple challenges, including substance abuse, chronic medical issues, and psychiatric disorders. New Choices operates 7 OASIS certified programs consisting of 4 community residences and 3 chemical dependence outpatient programs. Recently, New Choices assumed responsibility for other agencies who were experiencing programmatic and financial difficulties. The Bridge Center and Carver Counseling Center. Both programs are now fiscally viable and have received renewals of their operating certificates for the maximum period of 3 years. All of New Choice's OASIS operating certificates are in good standing and have been issued for the maximum 3-year period. A most recent fiscal viability report was done, and the current ratio of 2.16, overall ratio of 2.41, which would result in a 3-year substantial compliance. A plan review was conducted in October, and the inspector states, "My review of the floor plan reveals the proposed space appears that it will comply with Part 814 facility regulations for the service to be provided. Physical plant construction will be done in the future once the site is ready. We have LGU approval and field office approval, and staff, certification staff approved contingent upon the final facility inspection."
That's it?
That's it.
Okay, when's it gonna be ready?
April 10.
April? April.
What
We
year?
have the provider here, if there's any questions as well.
Yeah, April of what year?
2018?
Correct.
Okay. All right. And the other building, despite being built by Masons after 120 years, is, I assume the building's structurally sound, you're just insulting the infrastructure and the layout? The old one, not the new one.
Yeah, I mean, the building consists of 5 floors. The 4th and 5th floors are unusable for our purposes. They're large. The 5th floor is actually a Masonic temple. So we've outgrown the facility. The facility, we're selling it, we own it, we're selling it, and we have a prospective buyer. So the purchase agreement with Highbridge to buy the new building is contingent on the sale of our building, so we got a place to move.
Got it. So the temple's up on the 5th floor, they still use it?
No.
Huh. What happened to the Masons?
It's going to another lodge.
No, they're not, I assume there's another lodge somewhere
Oh, yeah.
in the air.
There's
All right.
lodges. I mean,
Well, no, worry about the spiritual health of everyone here. Okay.
the truth is to why
And the
we
money,
got... Yeah, go ahead.
I'm sorry, go on.
No, I was going to say, the real reason we got to get out is I've been telling my 93-year-old Jewish mother it's a synagogue on the 5th floor. And she wants to come see it.
I think
That's
this is
all right.
a live stream, by the way. She'll know now.
All right. And how does the money work on this? Of the 6.2 million, this is all state money? This is, how does this work again?
State money.
You can remind us?
It's state money.
Okay. So at the end of the state spending this money, who owns what?
Help, Jeff?
Well, the provider will own it with city grant lien and a mortgage, a bond mortgage placed upon the property for, the city grant lien will be for 30 years, mortgage will be minimum of 20.
Okay. All right, and all the fiscals were done. Okay, any committee or council members have any other questions? Okay, so motion will be to approve this construction project with all the money that is involved, capital project. Seeing no further discussion, all those in favor of approval, please indicate it. Waving aye. Is anyone against or abstaining? Okay. So that looks like it passed unanimously again. Thank you. That leaves us with one other project. Correct, this is Ocean Recovery East?
Correct.
This is Michelle
All
Woods.
right.
I'll be presenting this application. And we do have representatives here from Ocean Recovery East.
All right, is there anyone who signed up to speak who is not either a consultant or the applicant?
No.
All right, fine. Okay, so let it
Okay. Ocean Recovery East is requesting our approval to become a new provider of Part 822 outpatient chemical dependence treatment services and Part 816.7 medically supervised withdrawal services, 18 beds, which will be located at 113 East 60th Street in New York. The program will be based on the NIDA 13 Principles of Effective Addiction Treatment and will provide individual and group counseling, offer medication-assisted treatment, and encourage self-help participation. The applicant proposes to treat older professionals, many of which are addicted to prescription medications. They state that this particular population is currently seeking detox and treatment outside the state of New York because some individuals are not comfortable entering chemical dependency treatment programs that treat patients from a different socioeconomic background, mainly those with extensive criminal justice histories and or persistent mental illness. The program will serve individuals with private insurance or be self-pay patients. Ocean Recovery is a Delaware limited liability company which was formed in April 2014. The registered office and registered agent are located in Camden, Delaware. A copy of the State of Delaware filing receipt was submitted with the application. They became authorized by the New York State Department of State as a limited liability in the state of New York in April 2014. The applicant submitted a draft certificate of amendment for the LLC that includes the required OASIS operating language. The corporation is owned by 4 owners. Paul Schwartz, who has 51% of the company, he's in Manhattan Beach, California. Kathleen Tunney has 17%, Mr. Kevin Cullen 17%. They are both of Newport Beach, California, and Mr. John Krepsak has 15%, and he's in Staten Island. Kathleen Tunney and Kevin Cullen are current employees of Ocean Recovery, which is an LLC, a CARF-accredited chemical dependency residential treatment services located in Newport Beach, California. Paul Schwartz is a real estate broker and partner in that company. Mr. Krepsak is a licensed clinical social worker and internationally certified alcohol and drug counselor with at least 25 years of clinical, supervisory, and administrative experience in substance abuse and mental health treatment. Kathleen Tunney has her bachelor's degree in social work and is currently the executive director of Ocean Recovery, which is a 36-bed residential program for men and women. Kevin Cullen is the CEO, and he's attended 40 hours of an addiction lecture series at the West Coast Symposium from 2012 through 2016. Paul Schwartz is the chief financial officer for the business, and he'll provide the startup capital, regulate cash flow, and review budgets and distribute profits. A fiscal viability was conducted in October of this year and determined that their current and overall financial position is viable. The applicant submitted proof of funds for the first 6 months of operation and was able to present a U.S. Trust Bank of America statement in the amount of $6,934,000. The proposed annual operating budget for the medically supervised withdrawal treatment service shows $2,772,000 in expenses and $5,089,000 in revenue. Staffing for the medically supervised service, I can list that if you'd like. It meets our requirements. Okay. The operating budget for the outpatient chemical dependence treatment service is $907,000 in expenses and $2,190,000 in revenue. And that staffing as well meets our requirements. The local governmental unit and the OASIS Upper Manhattan field office both recommended approval. The applicant attended a Manhattan Community Board meeting to notify them of their plan, and in response, the Community Board sent them a letter basically showing their support. A floor plan review was conducted by the OASIS Facilities Evaluation and Inspection Unit in November of this year and determined that the proposed space is adequate for the intended purpose. The recommendation is to approve the application. There are 4 contingencies. One is a copy of the filing receipt from the New York State Department of State for Ocean Recovery East, inspection and approval of the completed facility by OASIS, a copy of the certificate of occupancy, and acceptance letters for all required staff positions.
That's it?
That's it.
Okay. So the applicant is here somewhere?
Correct.
Down here or?
Yep.
We're in Albany.
They could, all right, so if they're in New York, you may want to come up to the table because I don't have the microphone.
No.
And if they're up in Albany.
We're in Albany, Dr. Martin.
Okay. Interesting. Okay. So, I know I have a few questions. I guess I'll start off with, what the irony of this is, it seems to me, is that, there's a line here that you took from the New York City Department of Health and Mental Hygiene Goals and Objectives. Quote, we know there's an increasing need for services and also that stigma and lack of knowledge interfere with people accessing care, therefore increasing services as well as awareness of effectiveness of services are critical. But it seems to me the entire basis of this request is that there are people who don't want to be seen with other people with the same issues, and we're fleeing the state because they don't feel comfortable being treated because of stigma and other issues, I would argue. And now they'd like to build a contained facility that would make it more comfortable for them to be there, but not mix with people with the same sort of issues. So I'm a little confused at the logic here and would appreciate some discussion. But I guess I'm saying I don't understand the need. The fundamental thing is I don't see anything here that says there's a particular need for this project. We're saying that we're underbedded in Manhattan and the like, that's one thing, but I don't see that. What I'm seeing is that there's a niche of people who would prefer to have a different treatment location than what they have now, but not that the services aren't available. So that may be completely wrong, but I'd like to hear some facts to explain this to me.
So I'm Kathy Tunney. I'm one of the principals. The narrative doesn't...
Can you just...
Oh.
Can you just wait so I can see?
Oh.
You're very small. Oh, I got you. You're probably not... You're probably life-size.
Yes.
Go ahead. Gotcha. Thank you. Sorry.
I don't know what to do. So tell me what I want to address.
I got you. Okay.
Okay. So the narrative, I appreciate that narrative, although I think the origins and the genesis of this project had very little to do with that. I've been a provider of substance abuse services for well over 30 years. I'm born and bred in the Bronx. I'm a New Yorker, but I've been out in California a long time. When we started this project, and I've been hospital-based services, it was from John Krebsak's idea of having a non-hospital-based detox service with an intervention model that could provide services. It's not exclusive. That was never my goal. It's not my goal with the services that I run now. So it does offer an insurance-based and a self-pay component. That's a huge part of this. That is the part of this for a lot of people that do not seek services in hospital-based treatment centers. So that it would exclude a whole sense of population or make an already stigmatized population more elite, that is not the narrative that I experienced, nor am I interested in providing. So I don't...
Okay.
We really...
So, no. Well, then I'd ask the follow-up because I don't have the fiscal... the information provided for it, there's no real projection of... There's a projection of your profit, which is pretty impressive. And you're projecting $3.5 million of profit the first year. We rarely see that in this committee. But I'm not sure how you're getting there and what your expectation is in terms of people who are not just uninsured but don't have the cash to pay, or those on Medicaid or the like. So I guess I'm asking what sort of case mix of insurance and self-pay are you expecting or willing to provide in your first year or so of operation?
Do we have a number? Actually, I don't know that I have that number. We do? Sherry will look it up for you.
I mean, the answer is...
The question, the bottom line question is how much charity, bad debt, whatever we're calling it, are you prepared to provide?
That's a great question, and I presented for two with the commissions in New York City, the two
Community boards.
Community boards, I'm sorry, so I get confused. So we presented between two community boards, and that question came up. What I can tell you is, as a provider, what we've always done is really try to provide the service, and I have offered many scholarship beds and many reductions in rates, and as a for-profit in Newport Beach. My intention is to, make sure every phone call, everyone who does call has an opportunity for care. And if I'm the person that can do that, I know that it's inbuilt in our system now to provide some flexible payment or reduction and/or flat-out scholarship beds, and we do it. And that would be the same complexion that we would provide here in the city of New York. Some, I don't know. This has never been done, which really made it more enticing. So what this actually is going to flesh out to look like is interesting as providing this. I do know that as a non-hospital-based provider of this service, we can offer a lesser, the per bed per diem is much less than at a hospital-based service.
I just want to add that the genesis for this project was they are seeing a lot of the patients in California are actually coming from New York, and they were getting feedback from patients in California saying, gee, we wish you had services in New York. That was the genesis for the idea. And so that was how it started. When they went to the community board, because before, we talked about it ahead of time, that this is just a seed of an idea, you need to get community support or this is a no-go. And the community board voted unanimously to support this project, which, as we all know, is very rare in these instances. They have complete community support, so clearly the community feels a need for this project.
Well, all right.
Which is rare.
I won't, but I'll keep my thoughts to myself, which is rare. All right, but again, well, I'm not, how is it, but Oasis, is this the only program of this type in New York City? A non-hospital based program providing these services?
No. I think what she means is a non-hospital based program which is not focused on a Medicaid population. Most of the medically supervised withdrawal services in the city are primarily majority Medicaid population.
Yeah. Well, I don't know if they're focused on it or they're just representing those are the people who need the services to a large extent and they're going to use them. I'm not sure that they're exclusively looking for Medicaid.
I think we all know that addiction affects people in all walks of life, not just people on Medicaid, and so the fact that these facilities are only serving individuals with Medicaid is kind of interesting.
Well, yeah, and unfortunate probably. And the fact that they can't fly out to California and get care there is also unfortunate for them, perhaps.
I think people would prefer not to have to fly out to California. I think that's the whole point.
Or we certainly would want them to be stable before if they're going for rehab or some other service, we'd like to make sure that they were medically safe.
If we can keep them in their own community where they have family supports, that's always preferable.
Right. Unless you don't want to be treated in your community for a variety of different reasons, which is also what you're kind of implying for some of these people, but they'll stay here. Wonderful. I'm still, though, because we've certainly had this is not the first time we've had this conversation. And usually we are able to get and this may just be because you weren't prepped for it beforehand, is that we generally have a better idea of what sort of scholarships you're offering, or I believe is the term of art in your field, or the like. So if the 18 beds, I guess we're with the 18 beds that we're looking at and the tremendous fiscal viability that you're projecting, is what sort of, just what's the percentage, I guess, of the care provided going forward do you think you can comfortably tell us would be provided to those who don't have private insurance or an ability to pay the going rate?
So
there's a lot of noise in the background, so please, if you're near a mic, please don't rustle papers and the like. Sorry. Go on.
We had already, when we spoke with the community board 8, there was a commitment already for 10%. There may be more. Again, I'm not the financial person. but I am committed, again, for the service and to continue to support where we can. It's possible to do more. I don't think it's possible that we would do less, but we could make that commitment, clearly.
The community board was very clear that not everyone that resides there can afford those services, and it was a concern of theirs, and we did make a commitment at that time. We hadn't fleshed out what the exact percentage was.
Okay.
But we certainly want to be good neighbors and provide services.
No, I understand. And I appreciate the fact that you made that commitment. It's just not available to us. But that also means, I presume, that you would be okay if there was a contingency from the council that would put down some number that you'd be able to commit to.
Yes, absolutely.
All right. Okay. Well, we can discuss that more in a minute. All right. So I've been monopolizing questions. I suspect there may be other council members that haven't. Some. So is there any?
Glenn, I want to go back to the scholarship. So what I thought I heard was a 10% estimate of what. Is that what I heard? 10%.
Yes.
Okay. Thank you.
Okay. Is there any other question from anybody? Also, just parenthetically, the field office comment, the closest OP is more than 10 blocks away. I mean, that's a half a mile. Even I can walk that. And arguably, exercise is important for mental health, physical health, and probably staying straight. All right. So, are there any other questions for the applicant from anybody? Is there anyone from the community that signed up?
No.
Just checking one last time. Anyone in the community who didn't sign up but thought that we'd recognize them anyway?
Nope.
Okay. All right. Any discussion among the committee? All right, let me try to provoke some discussion. So, would the committee feel comfortable with suggesting when we go, would the committee feel comfortable when we make a recommendation up to the council that we discuss the conversation we just had and suggest that as a contingency, 10% commitment to whatever the term is, and we can discuss it with legal before it goes, about charity care, yada, yada. I hate charity care, but whatever the term is that we're going to use, be a contingency going forward.
Yes.
Yeah, are
Yes.
Yes.
committee member comfortable with that?
Yes.
Okay.
Important. Yeah.
All right. Ralph's got a question or a comment.
My question for Oasis would be, how would that be monitored?
That's a good question.
Yeah, actually, if I could, I think we owe the committee and the council an overview of that, which I'm hoping to do. We'll work with Janet and Oasis on that at the next council meeting.
We have put conditions such as this in the approval letters before. The ones that come to light are not yet operational, so the issue of how to follow up on it, we haven't addressed yet, but we'll come up with something.
All right. Yeah, I suspect the problem, frankly, in the public health planning thing where this comes up, we have, and for the consultants are ready to jump on me when I get it wrong, that basically we put these contingencies in not infrequently in ambulatory surgical centers, for example, that get limited duration CONs. But truthfully, if they don't meet it, it's a little unclear what happens, because even if you don't approve the CON, it doesn't magically disappear either. So the teeth is a little bit different and unclear, I would say, throughout the state. Having said that, though, the public policy intent is pretty damn clear, and we can make that clear now and then hope that the teeth grow in over time.
So you do have a metric in place to check? Oh, you don't?
We don't. That's what we need to build in, but we have added the condition to contingent approval letters in the past. It's just that those particular programs are not yet operational.
Because I'm sure it's going to be more than 10% just based on my operation now. The question is it full scholarship, or is there a reduction in fee or a small fee? Are those part of the?
I believe Dr. Martin is talking about 10% full scholarship, right?
Full scholarship.
Yeah.
No, well, I'm willing to, I mean, look, because you guys, your field uses terms like scholarship and the like, frankly, that just doesn't sound right to me, but that's fine. I'm talking about just in general, if you're gonna give 10 complete free ride 10% free ride scholarships and additional, that's more better. But I'm looking sort of at a total, so you're basically saying that you would commit to at least 10% or more in terms of the total nut, but recognizing there'll be a significant number of just complete free rides under a scholarship for those who need it, as well as reductions, etc., which is fine.
Yeah, let's just be clear, just so because I want to make sure we all understand. So the
Please.
is the 10% some sort of significant reduction, or is the 10% you stay in the bed and pay nothing?
That's up to the committee, but I think they're saying 10%.
That's what I'm asking. We're just trying to clarify.
And you stay in the bed and pay nothing.
Yeah, I would.
So I would think 10% would be regardless of the ability to pay, you would accept people. If they can pay something,
Right.
then
It's sort of a tenet that you want people to have some skin in the game and be invested in their treatment to some extent.
Yeah.
So to the sliding scale fee or something that makes sense like that, but
right.
I think would be fair and reasonable and clinically appropriate. Does that make sense?
Well, what we found is that when you give people a discounted rate, you're able to treat more people. I mean, there are more people that we'd be able to provide the scholarship for. I mean, it's just like a university scholarship. You can get one student in for a free ride, a full ride, but you can get 10 or 20 in if you're reducing the cost of tuition.
Yeah.
So
and on the other hand, the person who needs the full ride, though, wouldn't be able to go to the school if you don't give it to them. So, no, I understand what you're saying. I'm not. And again, if we had a clear formula, we wouldn't be having this discussion. And clearly, Oasis at this point isn't in a position to do that. So that's why I'm saying somewhere in between this meeting and the committee, we'll have a sidebar and try to come up with language that makes some sense from both sides. I mean, I said there's no confusion going forward.
Right.
There's no attempt to play gotcha. It's just trying to figure out the best way to word it. That's all. And I think the intent's clear. Right. There's just there's clearly a lot of need. It's not just for people who can pay or are well insured that are willing to pay. That need exists, and that should not be ignored. And I'm not saying you're going to. Luckily, you're projecting a very fiscally sound facility and program that should be able to provide a decent amount of that and still allow you to function well and have the necessary profit on the side. So we just need to word that in a way that we're all happy with. At least that's my intent, and I suspect we can do that, but just not in the next 30 seconds.
Right.
All right. Yeah, so that's why the motion, I just need people to understand that, because the motion's going to be, a little bit less precise than it should be, shall we say, but hopefully will be precise enough to allow us to move forward. So I'll try again. So I would make a motion, which I know I can, that the committee recommend to the council approval of this project contingent on a commitment for 10% or more full scholarships, reduced fees, or the equivalent. Details to be worked out with Oasis, period. Does that seem reasonable to at least from a reasonable as a formulation?
Yes.
For us?
Yeah. All right.
Excellent.
Oasis is comfortable with that? Okay.
Yes.
All right. So that's the motion on the table. Any further discussion about that? Okay. Then I guess we'll vote on it. Council members, if you could vote, all those in favor, please wave and say aye.
Aye.
Aye. Anyone voting in the negative? Anyone abstaining? Okie dokie. So thank you very much for coming and participating. That's helpful. And we'll see, as I said, we'll chat in between the two meetings and try to nail it down so the committee can vote on something. a little clearer. All right, so I think that does it for Oasis.
It does.
Okay, so that brings us to OMH. Just give me a moment.
Thank you.
All right, so Keith, I imagine you're presenting.
Yes, sir.
I'll let you decide. I'm guessing Integrity Care Services will take a little bit more time, perhaps. So why don't we skip that one to start, and then why don't we start off with why don't we just go on the RU system capital project to build, enhance, or otherwise change a CPAP up in Clifton Springs. This is MHA 2766.
Yep, and I believe we have representatives for the applicant in Rochester.
They're here.
Hey.
All right.
Okay. So, MHA 2766, RU System Inc., Clifton Springs Hospital and Clinic. The applicant requests approval to renovate and relocate within the hospital their existing CPAP to better position the program to serve the needs of the community, improve efficiencies, and reduce unnecessary emergency room presentations. The proposed renovation and relocation includes moving the 4 EOBs from the inpatient psychiatric unit to their own space, relocating the CPAP rooms out of the emergency department to an adjacent space, and to centrally locate the entire CPAP team in order to improve the efficiency of the program. The total project cost is estimated at $2,244,764 to be funded with a district capital restructuring financing program award. At the time the program was established, physical plant limitations resulted in the EOBs being located on the existing psychiatric inpatient unit and the crisis intervention beds being housed in the general emergency department. The current design has not been ideal in terms of efficiency or providing optimal patient care, and that has resulted in past citations from OMH. OMH has additionally had concerns related to adequate psychiatry coverage for the program, which have been shared by the surrounding counties and their DCSs. In particular, they issued a regulatory waiver by OMH related to psychiatric coverage for face-to-face evaluations for complex, high-risk presentations. OMH has cited the program for failing to have such presentations completed by the psychiatrist in a timely manner, especially during off hours. During the PAR review process, OMH conveyed to the hospital that it was not intending to continue with renewal of this past regulatory waiver, but would be willing to consider telepsychiatry as an alternative. OMH then worked with the applicant to assure that their proposed use of in-person psychiatry time of 60 hours per week was maximized during the identified peak hours, while supplementing this coverage via telepsychiatry during the known off-peak hours. The hospital concurred. As a result, OMH and all neighboring DCSs are recommending approval of this application.
All right, so
Dr. Mark?
Yeah.
Dr. Mark, John Lee. I've been advised I should recuse myself because I'm on an advisory council of the parent company, so I just want to share.
Thank you. Your recusal is noted. So, all right, I'm a little confused. So when we're all done, we end up moving what, where does it end up being, and how's it staffed?
Do you want folks in Rochester?
The applicant, yeah, I would think the applicant probably in the best position to answer that.
Yeah, sure.
So
my name is Joe Majalskis. So what will happen is the observation beds, the 4 of them that are currently on the inpatient unit, will move into the newly renovated space. There's currently 2 CPAP dedicated rooms in the current existing emergency department. We will expand that to 4 in the new dedicated space. And also our CPAP team is now located on the other side of the hospital. They will also move into this space so we can have a centrally located hub. Currently in the emergency department, where we have the CPAP rooms, that's being staffed by emergency departments personnel, nurses, techs, what have you. We will have our own dedicated nursing and technician staff, along with support from security in that space. And obviously by moving the observation beds off of the inpatient psychiatric unit, the care that's currently provided by that team will also be provided by the team of nurses, techs, and security in that space, along with the clinical team that does the mobile crisis visits and the CPAP evaluations.
So they're going to be in a separate unit next to the ED, the regular ED, or where are they going to finally end up
Correct.
located?
Yep, it will be adjacent to the existing emergency department.
Okay, separate, but it'll be a separate entrance, separate facility, separate unit?
Correct, yes.
Okay, it'll be locked or open, or you don't?
It will be locked.
All right, so you'll have a separate entrance into the CPAP, but it's contiguous with the regular emergency room? Okay.
Yes.
All right. And before this, you weren't at all? And you didn't have dedicated staff or anything, but you were called the CPAP?
We have dedicated clinicians, so we call them psychiatric assignment officers. So these are clinicians who will perform psychiatric evaluations both in the CPAP emergency department and in the community. So that portion of the CPAP existed. It's just the infrastructure of the patient care has been divvied up between the emergency department staff and the inpatient psychiatric staff.
All right, I'm sure that worked well. I'm amazed you could get a license to do that. I mean, things have changed since I've been locked in emergency rooms. All right, and it certainly sounds like it's moving in the right direction. I understand that. What else is there? Oh yeah, and how many hours do we end up with? 60 psychiatric hours per week is the
Correct.
end result of this? And how are you
Correct.
going to split that up?
Excuse me, I'm sorry to hear that.
How does that split up? 60 over the 7 days, how do you plan on doing it?
So about 80% of our volume comes in from Monday through Friday from the period of 7 a.m. to about 9 p.m. So that is our plan to cover that with in-person psychiatric coverage. And the other 20% or so of the volume would be supplemented by proposed telepsychiatric coverage.
So how many inpatient beds do you have?
We're licensed for 18 inpatient beds.
Okay, and you what sort of coverage do you provide for those at night? There's no on-site?
For the inpatient beds?
Yeah.
So we have a nurse and a technician on the overnights, 2 nurses, 2 technicians on the day and evening shift, and a psychiatrist there during the business hours and coverage on the weekends. We always have a psychiatrist on call, whether they're in-house or not, 24/7.
Right. And your definition of, and what's your expectation about their availability during their call? They have to be there in how much time?
Well, so our proposal is, during the 60 hours that the psychiatrist would be there, they would be able to respond to the patient within 60 minutes at the most. I mean, we'll have dedicated psychiatrists that will be at the CPAP, so that will be their only function. So the only thing that would propose a delay at that point is if there's multiple patients to be seen at one time.
Yeah, sure.
And then our expectation of our telepsychiatric coverage on the supplemental hours, I believe, would be 90 minutes. And that would be well within the confines of what OMH is asking.
That's right, so the telepsychiatry would I assume, occur more promptly than 90 minutes, but you'd still have somebody live who could get there within 90 minutes if there was a need?
If there was outside of business hours?
Yeah.
Well, we would be proposing to have the telepsychiatrist do that. We do have live psychiatrists who would be on call that could come to the building if absolutely necessary. We do always have it intact. The psychiatrist, I think, that lives farthest away from our hospital is less than 1 hour away, or approximately an hour away.
Okay. So let me ask OMH, you guys haven't been thrilled with the staffing pattern and the like up until now, from what I understand. Have there been direct repercussions to patient care as a result of that?
There have been no incidents that I can recall, to be honest with you. I would have to go back over to see if I'm forgetting any, but none that I can think of.
Okay. And can the applicant recall anything where there was, at worst case, a patient death or other really untoward incidents because of an inability to get coverage there in a speedy fashion?
I've been here for 3 years in January, and we have not had an incident of that nature.
All right. Thank you. And how busy are you?
So our current overall volume, when you combine our total observation beds, ED visits, mobile crisis, interim visits, and crisis residential beds, is running approximately 2,300 a year total.
Okay. All right. Any other questions by anyone from the council and committee who are allowed to speak? Ralph?
So the report said that the waits were anywhere from like 6 to up to 16 hours sometimes to see a psychiatrist. Do you have a goal of what an acceptable time frame should be that someone would see a psychiatrist?
Yeah, so our goal would always be within an hour, and with this proposed plan of implementing telepsychiatric coverage to cover our low volume periods, we would be able to accommodate 90 minutes or less, and 90 minutes is actually being pretty broad, but it allows us to deal with any technical setting up of equipment and things of that nature.
Okay, thank you.
And just to clarify, some of those outliers that had been taking a long time to see a psychiatrist, those patients come in sometimes and they're intoxicated. Sometimes they'll take 10, 11 hours to clear to even be seen by our team to begin with. So it would never be typical where a patient would come in, be medically cleared, and have to wait 16 hours to see a psychiatrist. But there are other factors that go into the medical clearance that will sometimes delay that.
Okay. Well, no, you got polite guys that used to make me go in and talk to people who were incapable of speaking, so you've got polite MER docs, is all I'm saying. All right. And the nearest CPEP to you would be up in Rochester, I guess?
Yes, that's correct.
And that's about, what, an hour away or less?
Correct. Yeah, a little bit less.
Yeah, all right. Got it. Okay. Cool. Any other questions? Okay. So, all right. I mean, just thinking out loud, I mean, I'm not 100% thrilled with the staffing model, but clearly you're moving in the right, and you're trying to build a physical plant that actually will allow for efficiencies and allow for things to be done right, which would be nice.
Yeah, Dr. Martin, I'd like to add that you know, OMH really does want to commend the applicant on that the staffing is so much better than what it had been. And as OMH indicated in the report, the local counties were quite concerned with this application throughout the process, and after working with the hospital on the staffing and the telepsych proposal, when I went back to the counties with that, they were all very pleased with the end result.
Yeah. Where's the telepsychiatry going to come from? You're going to get individual guys in the community to do it, or are you going to try to partner with the CPEP that's staffed 24/7 or something where it'd be a lot easier to get a shrink in front of a camera? Do you know you know how you handle that?
Hi, I'm Kathy McGuire, the senior leader for behavioral health for the health system, and we're actually using a pretty what we think is unique and innovative approach. We've got another disparate project that we're doing in Monroe County that will operate, for lack of a better term, we're calling it the Access and Crisis Center, but for lack of a better term, it's sort of behavioral health urgent care. Let's not call it that, since there's no such thing. But on the evening shift, that will be staffed between the CPEP staffing and the urgent or the Access and Crisis Center staffing. We intend to telepsych, obviously with appropriate applications. We intend to telepsych back and forth between those two locations, and so we believe that will provide pretty ready access to psychiatrists to telepsych for both of those locations. And then on the after hours, the intent would be to use our telepsychiatrists from approved locations, either in home offices, other locations, or other off-sites that we would properly vet and approve as part of our telepsychiatry submission.
Okay. All right. Well, that makes sense. I mean, especially the fact that you've got another service that overlaps to a certain extent in a different location, and you'll be taking advantage of that. So good. Thank you. All right. Any other discussions or concerns by members of the committee? If not, I would suggest that we can vote we'll put it in a positive form in approval of this request. So all those in favor, please indicate it. Aye. We have one recusal. Is anyone else abstaining or voting in the negative? All right, appears not. So we'll give our positive recommendation to the committee that will vote later today. So thank you very much for coming and giving us the information.
Thanks.
All right, next up is Erie County Medical Center, who would also like to do some CPAP work.
Yes, sir. MHA 2786, Erie County Medical Center requests approval for a significant renovation project for the CPAP with an estimated total project cost of $1,139,582. This project is multi-phased and designed to ensure that CPAP's existing operations remain fully functioning and operational with minimal disruption to patients and staff during the time. Phase 1 consists of renovations to the existing adult waiting room and registration areas to create a new reception desk with visual access to the entrance, along with an improved entrance to waiting area with adjacent areas for patient safety assistance staff. New space will provide a private interview area and a new exam room for patient evaluation and documentation before admittance to the CPAP proper. Minor modifications to support staff area are also included. Phase 2 will consist of renovations to the adolescent waiting areas to right size, relocation of the patient toilet room to accommodate a staff work area, and creation of a separate private evaluation area. Additional renovation of office space to create an area for medical students will also be created. Phase 3 consists of renovations to remove counseling rooms and create a second common area in the CPAP, allowing for separation of patients as necessary. Reconfiguring the nurses' station to improve access, creation of additional consult rooms, and acoustical improvements. Finally, Phase 4 will consist of minor renovations to the adolescent CPAP area for acoustical improvements at the nurses' station and the common areas. ECMC has the only CPAP in the Buffalo, Western New York region and has experienced a 20% increase in patient census since the CPAP was last renovated in 2014. The proposed renovation is expected to create a safer, more efficient space to enhance the patient experience within the CPAP, and OMH is recommending approval.
Okie dokie. All right, so you're gonna make it a little bit nicer. You're gonna add some room for staff. You're gonna make it less noisy. You're gonna still keep the kiddies and the adolescents away from the adults. Okay. Any questions from members of the council or the committee? Was anyone from the public registered to speak? I doubt. All right. Okay. So we have a favorable recommendation from OMH to beef up a functioning CPAP and the only one in town. So the recommendation, I'll make the motion in the form of a positive recommendation to the committee. Any further discussion? Seeing none, let's vote. All those in favor, please say aye and wave appropriately.
Aye.
Aye.
Anyone abstaining or saying no? All right, so it passes. We now move on to the Finger Lakes.
Yes, sir.
Yeah. Thank you.
They're saying thank you here.
Thank you very much.
No. Well, thank you.
John, aren't they staying for the holiday party?
I guess they got their own holiday party to go.
Hotel Henry.
Okay, MHA 2787, the Finger Lakes Area Counseling and Recovery Agency. The applicant requests approval to become an Article 31 sponsor for purposes of assuming the operations of a clinic treatment program for adults currently operated at 339 East Avenue, Rochester by Interim Healthcare of Rochester. No changes to services or capacity are anticipated as a result of this application. Finger Lakes Area Counseling and Recovery Agency, or FLACRA, was founded in 1973 as a private nonprofit agency serving individuals and families affected by substance use and other health-related disorders in the Finger Lakes region. Overseen by the FLACRA Board of Directors, the Executive Director, Martin Teller, has more than 36 years of experience in chemical dependency treatment, including clinical and administrative oversight of residential and outpatient treatment services. FLACRA indicates that the nature of addictions and mental health treatment are complex and that the two are often inextricably linked, and believes that best approach to successful treatment is through cohesive, coordinated care that is responsive to the needs of the individual. The applicant has expanded in scope and diversity during its 45 years history to meet the increased need for services in the communities it serves, and currently holds operating certificates in good standing from OASIS for 6 outpatient clinics, 6 resident services programs, and 2 detox stabilization programs. Flacker also offers community support services in the areas of case management, forensic counseling, peer support, and self-help groups, rehabilitation, education and training, employment, and home and community-based services. OMH is recommending approval.
Okay.
And there are folks from Flacker here. Dr. Martin,
Okay.
ask their question.
Okay, yeah. So, all right, they actually call themselves Flackra, okay.
I hope so, because I didn't want to say that if it wasn't true.
No, we do.
They're okay with
Yes,
that.
no, that's absolutely.
Yeah, that's fine. All right, so, well, yeah, well, the other interim health care is even more of a strange name.
It proves quite literal.
Yeah, right, apparently, yeah. So basically, interim wants to get out of the mental health business, and you're taking it over? Is that essentially what's going on?
Yes.
Okay. All right, and we said Flacker's been doing this for a while with no major issues, yada yada. Okay. And there are no changes to staffing or anything else, or programmatically at this time?
No.
Just to confirm?
Yep.
Okay. All right, and then the Monroe County contingencies, all right, pretty standard stuff, nothing of great interest. Okay. Anyone from the committee have any questions for the applicant?
I just have one, Dr. Martin. Given what you say about the need in Monroe County, are you expecting we will be expanding over time?
Yes.
To better accommodate that
Yes.
delays that we're seeing? 'Cause
Yes.
I know that's a big issue.
There are, as everyone knows in the room, significant delays, particularly, and so folks know, we do operate a detox and medically monitored withdrawal and stabilization program. Frankly, about 50% of the folks that we serve there are Monroe County residents, often waiting months to receive mental health services. So we really truly feel that this will be an opportunity for so many people that can get quick access to treatment. So,
thank you.
Okay. Are you participating in districts up there, or how are you tied in, or will be tied in?
yes, no, we are. In fact, Martin Teller is on their board, and so yes, we are intricately involved in multiple programs.
Okay. All right. Any other questions? Okay, so if not, the motion will be to make a favorable recommendation for this change of sponsor to the committee. Any further discussion? Seeing none, we'll vote. All those in favor, please say aye and wave. Aye.
Aye.
Anyone saying no or abstaining? Okay, excellent. We'll pass that along a little bit later. Brooks is next up, but we already took care of them.
Yep.
Thank you very much. Thank you.
Thank you for.
They say thank you.
Yeah, thank you.
We're polite and upstate.
We are.
All right. No, it's good. It's like everything's upstate. Well, not everything. It's good. No, when you're expanding and doing this, it's nice. All right. So this is SUNY. Oh, this is Syracuse. This. Right. All right. So this is Syracuse. This went to the FIPIC earlier. Has already gotten past the first hurdle at FIPIC. Oh, that's right. You guys want to open up an adolescent unit?
Yes, we do.
They're here as well.
No one ever wants to do that, so that's good. All right, so Keith, take it away.
Certainly. MHB 2797, SUNY Health Science Center, University Hospital. The applicant is requesting approval to expand its existing psychiatric inpatient treatment program to establish an 8-bed unit for adolescents ages 12 to 17, located at 750 East Adams Street in Syracuse. SUNY Upstate currently operates a 24-bed unit for adults on the 4th floor at the same location, and its total capacity will increase from 24 to 32 beds. In addition to this 24-bed adult unit, SUNY Upstate also currently operates a 25-bed adult psychiatric inpatient unit at Upstate University Hospital at Community General at 4900 Broad Road in Syracuse. Patients will be referred to the new unit from the CPEP at St. Joseph's Hospital in Syracuse, Upstate's Pediatric Emergency Department, and all other local hospital emergency rooms. The expected length of stay for stabilizing patients will be 5 to 7 days. The unit will work closely with OMH's Hutchings Psychiatric Center and Pinefield Psychiatric Center for adolescents in need of longer stays to achieve stability. It is expected that the new unit will significantly help meet the demand for adolescent care in the region, which boasts the lowest number of adolescent behavioral health beds available per region in the state. Residents awaiting inpatient psychiatric care at the Children's Hospital are often transferred to hospitals in Albany, Buffalo, or Ithaca, which present a burden to patients and their family members who must travel long distances to participate in patients' care. OMH is recommending approval.
Okay. And the applicant is here or there?
In Rochester.
Here in Rochester.
Okay. So will this also be a focus for teaching? Will there be residents rotating and the like, or medical students, or what?
Right now, we have it staffed with a child psychologist, a child psychiatrist, and a psychiatric nurse practitioners. There hasn't been a lot of discussion of any resident or medical student coverage, but most likely they will have support from the medical school. But the real focus is we do have a staffing plan with the psychiatrists dedicated to that unit.
Yep. Okay. Yeah, but these are the only adolescent beds that you have, right?
Yes.
Okay.
And just as an example, we do a safety call every morning in the Children's Hospital. Our census today, as a 71-bed children's hospital, we have 7 children awaiting placement in our acute hospital. We have 7 children in an overflow unit outside of the ED and another 9 boarding in the ED, all psychiatric holds, adolescent kids that are medically cleared, but we have nowhere to send them. So this is a throughput issue, it's a safety issue, and it's becoming an issue where we're not able to serve the rest of the community from an acute medical illness perspective. It's also putting a drain on the rest of the hospital system from a sitter watch because of the age of these kids needing one-to-one supervision. It's becoming a real challenge. We know that we can do better for these kids and their families, and while 8 beds is a drop in the bucket, it's a start at solving this in a better way than just holding kids and trying to send them 2 hours away.
Yeah, I was going to ask, so what do you end up doing? So where is the nearest provider that you could use at this point?
Right now, Hutchings, but it's difficult to get patients placed there. There is facility in Utica, but again, we have patients that are awaiting very long term. We've had a patient in the pediatric unit now for at least 2 months waiting for placement. So
they're basically boarding in the children's medical units.
Yes.
Yes.
Okay. And you're trying to, and that person's waiting to get into a long-term facility like Hutch, or just trying to get them somewhere?
Yes.
They are, and so the idea behind this unit would be having more appropriate psychiatric care available for those patients that could be medically managed within a week and then sent back out with a secondary process that you'll see in our application focusing on integrating them back into the community with amped up outpatient services as well.
All right. Okey-dokey. All right. Any committee members have any other questions or concerns?
How fast are you going to start?
As soon as you tell us.
Check back at 2:30.
Yeah, I mean, right. Department of Health may have, I think it meets next week before you can actually get totally cooking. All right. Well, you clearly have demonstrated need. Okay, any other questions, concerns? If not, the motion will be to give a favorable recommendation to the full committee later today. Any further discussion? Seeing none, we'll vote. Committee members, please, all those in favor?
Aye.
Aye. Anyone opposed or abstaining? All right, good. Well, congratulations, at least for this step.
Thank you, thank you.
Thank you for being here, or there, as the case may be. No, I actually didn't notice all the snowflakes behind you until, or whatever they are, I guess.
Yeah, they may be flowers, but they feel like snowflakes.
Okay. We'll probably have more.
Upstate thing.
Thank you.
All right, so next up is, where are we moving to now? Northern Rivers Family Services, is this it?
Yes, sir.
In Albany, okay.
Yep.
Glenn, I'm going to recuse myself. This
Well,
is
you're
Bill.
busy, Jeff. Yeah. Okay.
So, MHC.
Well, if I could just ask, the reason for the recusal is?
I'm CEO in Northern Rivers.
That's a good reason. Okay. So thank you for the record. Okay. Keith, take it away.
Certainly. MHC 2784, Northern Rivers Family Services, Inc., Parsons Child and Family Center. The applicant requests approval to relocate their existing residential treatment facility into new construction that will also include space for 2 future programs, a satellite integrated clinic and a crisis respite unit, through PAR applications that will be submitted at later dates. In March 2016, Parsons Child and Family Center was awarded a District Capital Restructuring Financing Program Award from the New York State Department of Health to build an innovative center for pediatric behavioral health care. This healthcare center will provide a full array of behavioral health services to children and youth in crisis, supporting rapid de-escalation of a crisis and preventing avoidable hospital emergency room visits and admissions. The existing Parsons programs that will be reorganized in this new facility are mobile crisis response, health home care management, behavioral health outpatient clinic, and residential treatment, with new services to be developed to include the integrated primary care and overnight crisis respite. The proposed center is a response to community needs identified in the Capital Region, Mohawk and Hudson Valley 10-county district community needs survey. Ultimately, the proposed center will provide a one-stop shop that would remove barriers to care by providing mobile outreach, same-day appointments to avoid unnecessary higher levels of care for children and youth in crisis, and offering services outside of the regular behavioral health hours of 11 a.m. to 9:30 p.m. identified in the survey. OMH is recommending approval.
Okay. And again, this is one where there's no change to staffing or capacity. The monies are coming both from the applicant and from the district. And it has the enthusiastic approval of everyone who weighed in, I guess.
Yes. And aside from the Honorable Mr. Getman, we have representatives here for the applicant.
Okay. So does anyone on the committee or council who are participating at this point have any questions for the applicant or for OMH?
Just wondering how the applicant is funding their share of the capital cost.
Well,
The 5.7 million.
The 5.7 is through private financing that is then supported by a business plan from existing services to pay the mortgage.
Okay, thanks.
Okay. What's private financing mean?
It's going to a bank. And,
Okay.
so putting out RFP, a bid, and a bank, we had a number of banks propose to finance us the money.
Okay.
So would the mortgage costs be somewhere in the expenses under the budget?
It's in the business plan.
So, Ralph, you don't see what you're...
I'm just not seeing it in the budget that we were given.
Yeah, hold on.
And maybe under OTPS? Or?
Yeah, we have the profit, the very simplistic profit loss projection expenses, and there's a lot of staff, which means staff and fringes, and then there's admin and OTPS, but the OTPS may not be adequate to pay for that mortgage, is what Ralph's suggesting. So I guess, and this is obviously not the most detailed approach. We just want to be sure that the fiscal viability assessment was done somewhere.
Oh yes, I can tell you that while we don't have them here in the room, our community budget folks have been actively engaged with with the applicant during this whole process, from award to even prior to the application being submitted.
Okay.
I apologize if I miss this. How many beds are we talking about in the residential treatment facility?
The residential treatment facility, when we submitted the proposal under district, included 20 beds. And it is now a 14-bed licensed facility with the intention to repurpose the additional beds for overnight crisis stabilization.
Thank you.
Okay. Okay. All right.
To get to Ralph's question, I apologize for not having more detail on the fiscal side, but it's been an initiative of OMH over the past year or so to really work with the RTFs around the state to try to get them to think innovatively about how they're going to survive in the new managed care environment moving forward. There's a belief that RTF as a model in a lot of respects is becoming obsolete, and that the applicant in this case sort of ahead of the game in coming up with an innovative proposal, working with their district team members, that OMH was fully supportive at the outset. So I can tell you that the fiscal folks worked very carefully to make sure that the project described is one that will be fiscally viable for them moving forward.
Thank you.
All right. Okay. Any other questions from committee members, council members, anyone? Okay. So we'll phrase the motion in the positive. We'll give a favorable recommendation to the committee later today to approve this project. Any further discussion? Seeing none, we'll vote. All those in favor who are voting, please wave and say yes. Yes.
Yes.
Okay. One abstention for the recusal and any no's. Okay. So that passes. And we move on then. Yeah, good luck.
Thanks.
All right, now we move a little bit closer to home. At least my home. Your home. Urban health plan up in the Bronx. I hear rustling, so I suspect there are people here now. Are there any community members who are scheduled to speak? If not, so I assume the applicant's here and the consultant's here, and you're there for questions. Otherwise, you'd be happy to run out without it. Okay. All right, Keith, take it away.
Okay. MHD 2783, Urban Health Plan, Inc. The applicant is requesting approval to become an Article 31 sponsor for purposes of assuming the operation of the already existing Vita Guidance Center located at 4419 3rd Avenue in the Bronx and Vita Guidance Center at St. Vincent de Paul Satellite at 900 Intervale Avenue in the Bronx, which are currently operated by Communal Life, Inc. Urban Health Plan, Inc. is a federally qualified health center with over 40 years of experience providing primary health care in the Hunts Point, Mott Haven, and Morrisania sections of the South Bronx. In addition to their primary location, UHP operates 9 satellites, 11 school-based health programs, 2 part-time facilities, and 3 administrative program sites. The applicant has also been providing mental health services under the 30% threshold of annual visits at their FQHC. The Vita Guidance Center provides bilingual, bicultural program with an expertise in serving the Latino community, as well as providing services to other underserved populations in the Bronx. The applicant intends to maintain the current staff to continue to provide the culturally and linguistically sensitive mental health services that the service area needs, while the current sponsor has been operating at a loss and projects that it would no longer be able to subsidize this program. UHP believes that with its long history in the community and its existing infrastructure, it can preserve the services provided to the community by the Vita Guidance Center. UHP is currently in good standing with the New York State Department of Health, and OMH is recommending approval.
Okay. Are we just servicing adults here?
I believe so.
Yes. Age 5 and above. Children, adolescents, adults, and seniors.
All right. So, why don't somebody come to the table so everyone can see? Whoever would like to. We don't need a whole ton, but. And if you'd like to introduce yourselves, that would be nice. And then we'll...
I'm Paloma Hernandez. I'm the CEO at Urban Health.
Okay.
I'm Rosa Gill, the President and CEO at Community Life.
Oh, all right.
Cicero consultant.
Okay.
And Pamela Timmons, a consultant.
Okay, so let's start again. So this is not just an adult program. This is kids up. All right. So from the staffing, I was just looking at staffing. So it just says 2 full-time psychiatrists. I didn't see anything here about the qualifications specifically looking at adolescents and children.
One of the psychiatrists who was there, who has recently resigned, was a child psychiatrist.
Okay. So the expectation
Is that we recruit and hire another.
Okay. Good expectation. All right. How many? And so this applications always confuse me. How many? You have 580 active patients, is what you're suggesting?
Yes.
And how many of those are going to be kids versus adolescents?
I'm not sure what the breakdown
It's
was.
about 200 children, I think.
Yeah, right.
All right, so it's a big, okay. But 200 is not.
It varies over time.
All right. All right, so we have 200 kids and their families. We've got 1 psychiatrist, child and adolescent for that definition. All right. So the parent program is unloading this now. So what's going on with so Communal Life is staying in business, just doesn't want to do this center, or what's happening?
No.
So, yeah, what am I confused about? All right, go, please, Rosa, go.
The reason why we are in need to close this clinic is because financially it's not any longer viable for Community Life.
Okay.
And therefore, we have a commitment to continue to serve the Hispanic and other communities we runs and our partners, Urban Health, that's the best thing to need to serve.
Okay. Well, just what caught my eye, and which I'm still a little confused about, because UHP is projecting you're going to make $1 million a year, revenue over expenses. So that doesn't sound like a fiscally troubled program. So what am I missing here?
So I think what you're missing is the Urban Health Plan is a federally qualified health
Yes.
center, and we expect that this site will become a federally qualified site.
Right.
We have enhanced reimbursement, and we are also proposing to integrate a medical site in there. So we have an Article 28 CON that will be submitted shortly, so that we could do a small clinic operation together with
Right, so you're going to take advantage of the new streamlined primary care integrated programmatic application and the like, or whatever it is we've done. Cool. All right, so that makes sense. That's what I figured, but I figured I was going to ask what's going on. All right, so at the time being, you're going to keep the same clinic, the same staffing. You're going to replace the psychiatrist with another child psychiatrist. You're going to make more money, not because you're necessarily better or cooler, but you get to charge more for a variety of reasons. Plus, you'll integrate it, which is nice and probably a good step in the right direction. Not that I have an opinion. Okay. Questions? Ralph?
A large piece of your budget is Medicaid managed care. Can you tell us where you are with that? Is that is that solid already, or do you anticipate
most of the payers that are accepted, the larger payers that are currently accepted, Urban Health Plan already has contracts with, and they're all lined up in order to include this site as an additional site once we get the approval to do so.
Where are you on electronic medical records and integration or not with the Shiny?
So we have eClinical Works in place. We're part of the Bronx Rio.
Okay.
So the Bronx Rio will connect to the Shiny at some point.
Right.
And we're hoping to be able to integrate, as patients come in, the records from VITA into our eClinical Works.
But VITA's not using eClinical now.
No, they're not using, they use a system, but they print up the paper record.
Okay.
So what we're going to do is on a patient-by-patient basis, as they come in, get a release and get the information and scan it into ECW.
All right. That'll be interesting to see. But there are all sorts of challenges, frankly, but for another committee at another time. All right, good. Any other questions?
No.
All right. I was going to say from upstate, but the Times just had an article yesterday trying to define upstate. But apparently Syracuse has no problem, at least the school. They're upstate, so now I know what to do. Now I know where it starts. It starts in Syracuse.
It's fake news.
Yeah. Here we go. All right. Any other comments, questions, or concerns? If not, the motion will be a positive one to recommend to the full committee that we recommend the change in get sponsorship and movement of the program over to Urban Health Plan. The understanding that the empty psychiatrist who's a child will be replaced with a child psychiatrist. And I guess we'll go from there. Okay. And I would suggest, once we pass this, that the applicant, somebody be here for the committee meeting later.
Okay.
Because we have one member who is a child psychiatrist and generally gets very into staffing for good reason, and she actually knows what she's doing, unlike me, so it makes sense to let her do the questions. Because I'll give them a run anyway, and she's going to ask them. So all right. Any further discussion on this program? If not, I suggest we vote. All those in favor, please indicate it. Yay. Anyone opposed or abstained? All right, so we will give a formal positive recommendation for later today, and as I said, somebody stick around. These will be questions, I'm pretty sure, on today.
Thank you very much.
All right. Okie dokie. It's nice to know that you guys aren't going out of business. Like I said, it's just a little confused for a moment. All right, so we move from the Bronx down to, in Brooklyn now, Woodall. What is Woodall planning?
Well, I'll tell you.
Thank you.
MHD 2785, New York City Health and Hospitals Corporation, Woodhull Medical and Mental Health Center. They are requesting approval to decertify 23 psychiatric inpatient beds, thereby reducing total capacity of the inpatient program from 135 beds to 112. This request is related to an Easy Par application the hospital submitted in 2016 to permanently relocate the existing CPEP from the second floor to vacant inpatient unit on the fifth floor, and to increase the number of EOBs from 3 to 6. In order for OMH to consider that request, the hospital first had to submit a request to decertify the inpatient beds on Unit 1 of the fifth floor. Woodhull's adult inpatient service is currently certified for 135 beds across 6 units. The 23 beds on Unit 1 have been non-operational or offline since February of 2014. At that time, the psychiatric emergency room was temporarily relocated to Unit 1 to allow for the renovation of the original psychiatric emergency room on the second floor into a CPEP. The renovation was completed in November 2015 when the newly renovated CPEP was opened. Since that time, the unit has remained vacant. In order to relocate the CPEP to the space currently occupied by the vacant Unit 1, the 23 beds associated with that unit must be properly decertified. As a result, OMH is recommending approval.
All right. So did anyone signed up other than the applicant? The applicant's here, I'm guessing, somewhere? And there's probably consultants and other things. Okay, but we're just for questions.
Are here.
All right, but for questions only, if you want, you can come up, you can sit there and I'll have questions on the. All right, so Keith, this is, so we're not talking about the CPEP or anything else. All we're doing today is talking about going from 135 down to 112 on the inpatient CON, but you're saying that the drop basically reflects reality because no one's been in those beds for at least, 2 years now, maybe 3?
At least for 7 months.
Okay.
Yes.
Okay.
Almost 4.
Thank you. All right. Okay. Cool. This seems rather straightforward. What sort of wait times do you have now for psychiatric beds with this 112 configuration?
Well, our wait time is really around 4 hours, but it's what we find out looking at the reason for the wait time is really because we sometimes get stuck with gender-specific beds, but we since then implemented and we manage that more effectively.
Good. Yeah, I always asked the nurses to show me the appendages that showed me that it was a male bed versus a female bed. They all look the same to me. The argument rarely worked. All right. So So you don't really have a major rate, you can do without those beds, there's no indication that you were struggling as a result. Now you just want to do a CPAP that makes good sense in a good spot at the hospital. Lovely. Good. Any questions or concerns from anybody? If not, I would suggest we phrase it as a positive recommendation to the committee for action later today. Any further discussion? Seeing none, all those in favor, please indicate it. Any for voting members? All those in favor? Anyone opposed or abstaining? Okay. Thank you. You're very welcome. We'll forward our recommendation to the committee that will act on it later today. Thank you. Thank you. Good luck. All right. Okay. All right, moving along, what do we got? Sorry. Oh, that's right, we're jumping to Staten Island. Yep. Which is about as downstate as you can get. So we're but a whole other whatever. All right, I can say nothing that won't get me into trouble. All right, Keith, take it away. Richmond Medical Center doing business as Richmond University Medical Center.
Yes, sir.
All right.
MHD 2795. The applicant is seeking approval to close its 25-bed Bailey Seton inpatient adult psychiatric unit on Staten Island. Rumsey will decertify 15 of those beds while increasing the certified capacity at its Bard Avenue campus by 10 adult mental health beds. The new resulting configuration of the Rumsey psychiatric inpatient unit at the Bard Avenue campus will then be 50 beds, 40 adult beds, and 10 child-adolescent beds. The construction phase of this project is to be funded with the District Capital Restructuring Financing Program Award and cash equity. The committee may recall that in July 2016, the Council and OMH approved a PAR application from Staten Island University Hospital to close its 29-bed psychiatric inpatient unit on the agency's North Campus. OMH initially deferred that application at the time because we had just become aware of Rumsey's intent to close the Bailey Seton unit, which is the subject of the application now before you. Due to this concern, Commissioner Sullivan requested that the New York City field office of OMH conduct a meeting between Staten Island University Hospital and Rumsey to discuss both the short and long-range regional planning efforts for dealing with psychiatric inpatient need on Staten Island. Specifically, the parties discussed collaboration between Staten Island University Hospital and Rumsey regarding diversion and coordination of care and development of community alternatives and diversion efforts. It was a good discussion indicating the hospitals had indeed been consulting and will continue to, and had also been working with South Beach Hospital. Both hospitals had demonstrated a reduced inpatient length of stay to approximately 11 days, and the average daily census was generally below capacity. In addition, both had been developing and enhancing clinic and partial hospitalization services as well. As a result of these discussions, or that discussion, OMH was comfortable supporting both the Staten Island University Hospital PAR then and the Rumsey proposal now. However, I'd be remiss if I did not point out that OMH's analysis indicates that even at the lowest rate of utilization identified by Rumsey, the reduction in adult beds appears to result in insufficient capacity for Staten Island until the Bard campus renovation is completed in March of 2019. To address this issue, though, Rumsey plans to attenuate any capacity issues in the interim by decreasing the length of stay on the inpatient unit and bolster its outpatient services throughout its continuum of care, particularly its partial hospitalization program and intensive outpatient program. While tight, OMH is confident that the two hospitals will work together to ensure needed access and availability of services. In the longer term, though, OMH supports this application. The Bailey Seton facility is outdated, not a full-service acute facility, and has very limited medical consultation and support services available on site. Relocating the psychiatric beds to the Bard Avenue campus will allow access to and integration with the full range of medical consultation and support services available at the main campus so that the medical center can provide more integrated care for patients. In addition, Rumsey's main campus is the site of Staten Island's only CPEP, with beds for extended observation. Relocation of inpatient psychiatric beds to the main campus of Rumsey will allow for direct inpatient admission from the CPEP without requiring ambulance transport to the Bailey Seton facility. In addition, the relocated psychiatric beds will be in close proximity to Rumsey's mobile outreach service and medical center's patient-centered medical home, allowing for critical follow-up care to discharged behavioral health patients thereby resulting in fewer unnecessary ED visits, avoidable hospitalizations, and behavioral health readmissions. OMH is recommending approval.
So, let me see if I understand this though. You're suggesting that we're gonna take 25 beds offline, we're gonna put 10 of them back online, but in 2 years, and that by running a better, leaner, swifter, integrated, wonderful service, it'll all work without exploding and having to move people off the island. Is that basically what we're saying?
Yes.
I'm asking Keith. Okay.
Yeah, I wasn't sure who you were asking.
So if that's the case, why do we need the 10 beds back? If it's gonna work wonderfully for the coming 2 years with just doing new stuff or doing it better or whatever, why do we need the 10 beds back if we're gonna be able to survive for 2 years without these 25? Now, that's my confusion with the recommendation. Unless, so did I get it wrong with the first?
No, I think you raise a very legitimate question, and I think that, like I said, we do believe that the long-range plan works. We are concerned about the interim plan, and I guess some of it is an unknown. And going on trust, if you will, based on what we've seen out of the hospitals working together via the Staten Island PPS over the past couple of years.
Okay. No, I mean, all right. Well, Ralph,
So I guess I did hear that your assessment is that there would be a shortage during the period of time before the new beds came on. I was wondering if there was consideration for not decommissioning the beds until the new beds come on.
I think that is the request. That was what the application.
Keith?
I'm sorry, what? So you're saying take partial some of the beds offline? Is that what you're saying, Ralph?
Well, that's what we were asking. Well, there seems to be a little confusion even in the room among the applicant and ourselves. Is that so? All 25 beds, the expectation is Bailey Seton will get out of business as fast as possible. But is that accurate?
Yeah, actually, OMH became aware that the unit has already closed due to an expiring lease at, I can't remember whether it was the end of September or the end of October. But yes, so in some respects, we're sort of in a bind with the hospital at the moment. So I don't know. I don't know whether there's an opportunity to only take beds partially offline. I'd sort of need to direct that to the applicant at this stage.
All right, but now I'm completely confused. So Bailey Seton had 25 beds that we were going to end up bringing them down to 0 and move 10 over to Rumsey. As the basic plan. Yes. But now you're telling me that Bailey Seton has essentially already shut, and those 25 beds are gone, and have been for the last 2 months or so. Okay. Right, without increasing capacity anywhere else. All right, so how are things going on the island? I guess I would ask the applicant and OMH now without those 25 beds, if anyone knows.
Yeah, this situation has been in existence since October 1st, so it's a very short period of time. And during that time, as Keith described, Rumsey is using their full continuum of mental health services, CPEP, mobile crisis, clinic, a newly opened partial hospitalization program, which they are willing to expand if the need becomes necessary. So yes, at this point, whether this situation continuing to be manageable will continue past the time we're at right now is still somewhat unknown. And Rumsey projects that the 10 beds will be necessary. They obtained the district capital funds for them, and thinks that in the future they will be necessary. I mean, the other thing that's going on is the managed care is now being very conservative with their approvals for inpatient care, and the pendulum may swing back the other way you know, as providers start to push back on that.
Yeah, well, all right.
And in addition, while the application says an 11-day length of stay, we're less than 10. We're at about 9 currently. And at the Bailey campus, I think the record is to understand that throughout the course of the year, we'd seen a consistent decline from January. So while the action is taken in October, it was a consistent down. We were never at capacity throughout the year. And from the summer months, and as of May, we were in the teens and 10-bed capacity. While we were required to have full staff, full census, and it is a rented facility. It's not part of the hospital, and putting a very significant risk to patients in a situation like that. So it seemed that the cards were actually working its way down to a zero capacity. At the same time, the organization was aggressively addressing our overall length of stay. We went from 14 to 11 at the time the application was put in. As I said, now we're 9 and 10. Some of that is influenced, as Brian said, by the managed care impact. We're really not sure. I don't think anyone in the industry, and you folks as well know better than we do, if that is going to swing. But sometimes it is a very significant impact for the patients that are receiving psychiatric care in terms of 3-day or 4-day approval. We also have extended observation beds, 6, which we've managed to utilize in a different way. We've changed our methodology around using them. We're very, very conservative prior to this about keeping a patient in the required time under observation. Our goal was, see them in CPAP, get them in observation, and get them to the inpatient unit. So we've been able to maximize that opportunity now, and that really has helped. So it's a lot of moving parts. We are the only CPAP on Staten Island. And obviously, as you know, with that, we do have our mobile crisis, we have our EOB beds, and we do feel that holding on to those 10 beds is probably in the best interest of being able to move forward in the event that the pendulum does swing the other way. We're at, we've done our architecturals, we're probably a third of the way along, and the design was actually finished in terms of the 10-bed construction, which is immediately adjacent to the existing unit and not requiring any impact to the services of the inpatient unit during that construction. So things are just aligned in that way, happen to just, there's a little bit planned. Quite frankly, I would like to take a lot of credit for that, but not necessarily. Some of it has just fallen into place, over the course of time. We did not expect to see the psych inpatient beds at Bailey decline that rapidly over the course of the year. We did not, quite frankly.
And if I may add, our inpatient unit at the main campus, 355 Bard Avenue, has been licensed for over 35 years, and I've been associated with it throughout that period. And we have seen swings of anywhere from 5 to 10 beds, even when in the 80s and late 70s, when the hospitals were looking for to increase inpatient beds. So, given the district initiatives which are already underway, through several agencies on Staten Island, we just heard about the SIUH's, granting of the 27-bed, beds going offline. Our 25-bed application is here. So we anticipate that, given our experience, that this is just a sort of a temporary phase where we are at capacity on Staten Island. We haven't had to refer anybody off the island, but I don't know what is going to happen 3 months from now or 6 months from now. But historically, I think Staten Island needs 10 beds, and we are willing to take that responsibility. And its CRFP grant was given to us. We have worked very closely with the field office, New York City field office, and I think we are going to need those beds for Staten Island.
So it sounds like you're pretty far along with the plans, but the anticipated date of opening the 10 beds is not until March 2019. Can you do that quicker?
Construction has not started. Design is and architecturals are. We want to look at the next several months to see where is this trend up. Obviously that's an important aspect. If it should continue downward, that's yet another story. We've maintained very, very close communication with the office here, regarding our steps, and they were very, very familiar with the conditions that we were experiencing.
Somebody's mic is on, probably in Albany. Can you either turn it off or please be quiet? Thank you.
So as I was saying, we've maintained very close communication, with OMH office regarding all of our plans and our steps along the way, keeping apprised of the downward trend and where the organization was at that time. So again, our plan is to watch it very closely. We really do have it under a microscope. When we did close the unit, point of record, no patient had to be transferred either off the island at all, nor to another hospital on Staten Island other than Richmond University. So we had absolutely no impact of that nature at all. And we have not experienced that. We maintain our capacity, our access into our inpatient unit is very fluid. We do have a little bit of wait time when we refer to the state facility. That's for another meeting.
So it sounds like though you're not fully committed to doing the additional.
No, we are.
You're looking at trends.
I think we need to get permission here, and then we will move on. And another thing is, we are located on North Shore of Staten Island, which is the poorest part of Staten Island, and it's high medical comorbidity with a lot of our patients. And we feel an obligation to the community that we don't want Staten Islanders to go to Brooklyn, for psychiatric care.
So let me ask a hypothetical, if I may.
Yes.
You're not supposed to, but I will. This is costing several millions of dollars, right?
Yes.
If I gave you several millions of dollars and said, build the service that you really think is needed, be that an outpatient integrated primary care clinic with mobile crisis capacity and the like, would that be preferable to these 10 inpatient beds that you don't seem that you need right now? So that's what I guess I'm trying to wrap my head around is you slowly brought down your beds to 20 beds over the course of several months. You did so without disrupting care on Staten Island. You're working harder, probably, which is wonderful. But right now you have a stable situation, and now you're thinking about reinvesting millions of dollars of money back in inpatient beds, which doesn't seem to be what you need based on what you've shown in the last 10 months, and not investing it in something that might arguably be better for the community. Now, I don't know that, that's why I pose it as a hypothetical, but I'm still a little concerned about spending it in this way based on the track record you just gave me for the last 10 months.
Okay, we already have a integrated medical site care model in a brand new facility
right
at 1130 South Avenue.
Okay.
We have a crisis, mobile crisis team, which is very, very active.
Right.
I think one of the most active in New York State. And
they have every component of the continuum of care.
Yeah, and a couple of other things that are happening. Staten Island Mental Health, we are, our Staten Island Mental Health, the Children's Services is merging with us, so there's going to be even a broader.
Right. My point is not that you guys aren't doing a great job. I mean, you are, and you're moving in the right direction, you're integrating, you're doing all of that. My question is just, is this the best use of millions of dollars to build 10 inpatient beds as compared to taking, if I magically could snap my fingers, I give you all that money, you just do something else with it. Would it have made more sense to do something else with it? Is my issue. Obviously that got to deal with OMH and not you guys with that, but that's what I'm just sort of struggling with is why you
I think this is when you look at in spite of all the other services that we have, I think the extra inpatient beds are still needed when you look at the future. Not because claim insurance changes that may happen. Because Staten Island is always a growing community and the need for increased mental health services all the time. I foresee a situation where there's going to be need for more inpatient beds also because sometimes we get stuck with patients like both state hospitals and the state hospital beds are being reduced from gradually. So it becomes more difficult to pardon?
Next to nothing to next to more next to nothing.
It becomes more difficult to move some of those patients.
I would answer you to say hypothetically. My answer would be hypothetically. I believe we're making the right decision at this point in time. given what, where we are and what the, what the landscape is right now on Staten Island, where our organization is in terms of its location, in terms of the merger with Staten Island Mental Health, as well as the fact that we are going to be constructing a new ER that has a behavioral health urgent component to it, which will, yes, wider net. I do believe with the facts that we have today, this is the right decision.
The other thing is that Dr. Patel pointed out, the unit at Bard Avenue is running at capacity now,
right.
Since, and that's always, when you're running almost at capacity or at capacity, there's very little room for error.
There's no room. Yes.
And the 10-bed construction, as we said, is a district capital project. It's on that, and as you know, that's a 50-50 relationship. Percent the organization, percent the state. So we're mindful of that, and we really want to look to manage towards that. And as I said, as I see today, obviously, if tomorrow the bottom falls out, it's very different. I wish we had a crystal ball, but from the facts that we have, we feel strongly this is the best way to go for the organization.
Any questions from anyone else?
Glenn, this is Bill. Maybe I'm beating a dead horse, but why are we doing this now if the need hasn't been fully documented? I guess I'm asking Keith.
Well, you're talking about the 10 beds at
beds,
Bard,
yes.
And I think what we're approving more so than that is the downsizing at Bailey Seton. I think that's really the crux of this application.
Okay. That's helpful.
Yeah.
So they'll come back for the 10-bed ad? Is that what they're saying?
I'll be honest, I'm going to have to take a look at the paperwork on that. We may just simply be able to add it as a result of this application, but.
Yeah, well, the project description hasn't totally linked.
Yeah.
And frankly, whatever we do, they've already shut their beds, which is a whole issue we can argue, we can discuss some other time about, how beds disappear, whether or not this committee or frankly OMH knows what's going on.
Yeah, I mean, theoretically, the way I'm seeing it is that as a result of the passage of this application, those 10 beds will be added at least to the paper at Bard campus, but we will know that they are not going to be online until
2019.
Yeah.
Right, but they would be able to. But all right, I guess the bottom line though is if we approve this as written, does that mean they have the opportunity then to go forward and build those 10 beds, or do they need to come back and ask for permission to do that? If I assume not, if we're transferring it over to their existing CON. So in fact, we're doing both. We're acknowledging the fact that they've done what they've done, and we're giving them permission to increase by 10.
Yes.
Okay. All right, so we all know what what we'd be voting on. All right, is there any further discussion about what we now understand we're voting on? All right, so it seems to me there, I guess personally, I would ask to defer this a cycle and get OMH to give us a lot better discussion on why this makes sense, based on the concerns that I raised. But I think the best way to do this is vote on the motion, which will be to approve it. If that is passed, it'll go to the committee. If it doesn't pass, then we'll consider any other secondary motions at that time, if that's okay with the committee members. Otherwise, I can make a motion, but we're running this informally, so I think it's just fair enough to do it that way. So hearing no objection, we'll run it that way. So the first vote will be on a positive motion to support this at the committee later today. All those in favor of that motion, please say aye and raise your hand so we can keep account.
Aye.
So we have 4 people, 2 in Albany, 1 Rochester, and Ralph here voting for it. I'll vote against, but we will go forward then with a positive recommendation for the committee, and we'll discuss that later this afternoon. Okay. All right, I think that concludes business with that.
Thank you.
Excellent.
Okay,
Thank you. Thanks for coming down and answering our questions. And good luck with whatever happens. Thank you. And I know we're running a little long, but I think we're down to the last order of business. Am I right?
Yes, sir.
All right, so we have a, this is MHD 2759, Integrity Care Services, wishes to establish a clinical treatment program. This is a little unusual, because they're asking to do this despite a negative recommendation from OMH, but we will certainly listen and see what we're going to do. So I'm guessing the applicants are here, the consultants are here. Was there anyone from the community who had signed up for any discussion?
No, sir.
All right.
And and just so you know, we also have the applicant's legal counsel here as well, Mr. Melick.
As compared to these guys.
We're not attorneys.
Okay. So we've got more firepower than usual, which is fine. We don't normally start off turning somebody down, so that's not surprising that we have it. All right, and when's the full meeting starting? 1 o'clock?
12:30.
12:30? Okay, so we're running a little long, but I don't see lunch here either, so it's not great. Okay, so let us begin. Keith, take it away.
Yes, sir. MHD 2759, Integrity Care Services, Inc. requests approval to become an Article 31 sponsor for purposes of establishing a clinic treatment program in Borough Park, Brooklyn. The applicant is a not-for-profit organization formed by members of the Orthodox Jewish community in Borough Park in order to help community members to overcome the stigma of mental illness and develop greater access to mental health treatment for those with mental illness. The applicant indicates they have identified approximately 600 individuals in need of mental health clinic services who have supposedly experienced great difficulty in being linked with culturally competent services. They state that approximately 200 of these inquiries are from people with family members with a serious mental illness, schizophrenia, bipolar disorder, or major depressive disorder. During 2015, Integrity Care Services reports to have provided outreach and education services to 400 adult patients, including 100 patients with a serious and persistent mental illness. Throughout the PAR review process, OMH has stated that we do not believe a need to exist for the application proposed, particularly for a clinic specifically targeted to the Orthodox Jewish community in Borough Park, Brooklyn. In addition, OMH has not found the applicant to have themselves sufficiently documented in documenting a need for this clinic. In all of Brooklyn, there currently exists 64 OMH licensed Article 31 mental health clinics with 98 additional satellite clinics. In the community of Borough Park alone, there are 4 licensed clinics and 20 satellites. 2 of the 4 clinics in Borough Park identify themselves as specifically serving the Hasidic and Orthodox Jewish population, as do 18 of the 20 satellite clinics. An additional satellite clinic, likewise identified, is scheduled to open in January of 2018 with a projected monthly caseload of 250. Deferral letters on this topic were sent to the applicant on 4 occasions, as well as conference calls on two additional occasions. On a September call, OMH advised that the applicant's statements of need aren't supported by the documentation submitted, pointing out that 2 similar proposals over the past couple of years were ultimately withdrawn for this very reason. The applicant then asked if OMH would be amenable to them sending certified letters to the known clinics serving Borough Park, asking questions about their ability to serve Yiddish-speaking clients, including staff competency and wait lists. OMH was, and in fact assisted in this endeavor by encouraging the clinics contacted via letter to respond. The result, a copy of which was shared in your packet, supported OMH's determination that no need exists. Therefore, at the present time, OMH is recommending disapproval for a lack of need.
Okay, thank you. And just so we're all working off of the same playbook, did you send out any supplemental material about this after?
I did not. Just to yourself, I sent a map that I had folks.
Thank you. All right, so it's just a map. Okay. Which, if anyone wants, we can redistribute. But you said the numbers. Why don't we just review the numbers again? There were a bunch of.
In Borough Park, there are 4 licensed clinics and 20 satellites. 2 of the 4 clinics identify themselves as specifically serving this population, as do 18 of the 20 satellites.
Okay.
That's essentially what's demonstrated in the map that I sent you.
Right. Okay. Thank you. All right. So we do have some guests here. Why don't you guys introduce yourselves, if you would, please?
So I'm Joel Foreman, the applicant, the chairperson for the Board of Directors at Integrity Care Services.
Okay.
Frank Cicero, a consultant to the applicant.
Baldwin, consultant to the applicant.
Brian Baldwin, consultant.
And legal counsel, you said, was somewhere?
Yes, Peter Millock from Nixon Peabody representing.
Oh, there you go. Okay, I see you. All right. So, okay, so it seems to be a fairly straightforward, you guys want to open a clinic, basically saying you want to serve a population that you think is underserved and requires the special care that you'd be able to do, culturally sensitive, et cetera, and linguistically sensitive. In addition, and OMH is saying there are plenty of providers around who say they're meeting the need right now, we don't need any more. And I think summarizes fairly where we are. So I will ask you if you could just respond and let us know why OMH has gotten it wrong or what we need to understand the nuances.
Okay. I'll speak first before Mr. Folman. The question is there a community need for the proposed clinic by Integrity Care Services? Are there clients in Borough Park whose treatment needs are not being met successfully by existing OMH licensed clinics? And the person who first asked that question was Joel Folman, who's a rabbi and a member of the Orthodox Jewish community in Borough Park. He has a personal caring about the behavioral health needs of his community. His assessment comes from people in the community, hundreds of people, seeking him out when a family member has a mental health episode. And as a member of that community, he knows how difficult it is for them to reach out because of the stigma attached to the illness.
Is it possible to mute? Can we mute the sound coming out of Albany if no one is speaking? Because it's like really noisy.
I mean, we'll ask Dr. Marmot. I can tell you that nobody's been making a sound here.
All right. Yeah, no, then maybe it's not you. All right, well, now it's gotten very quiet.
Now it's quiet.
All right. Okay. It's much better, so I don't know what happened, but thank you.
Yes. Oh, thank you, Dr. Martin. He knew how difficult it was for these folks to reach out because of the stigma attached to mental illness in the community. His main goal was to help mentally ill individuals overcome their fears of entering treatment and to connect them to culturally competent mental health treatment programs. And the people that were reaching out to him included many, a majority of seriously and persistently mentally ill clients. And so he had an idea of what he could do to get these people into treatment and to have their treatment be successful. And over the years, he's helped many people, and Integrity Care Services is currently working with 50 people who would be considered by OMH to be high-risk clients. And the current group has experienced 97 inpatient psychiatric hospitalizations among them, 14 suicide attempts, and 32 of these over 50 people have a history of non-compliance with medications and treatment. So they've had either no treatment or very unsuccessful treatment in terms of their psychiatric treatment. Their experience with the mental health system was almost universally not successful. So what he did was he gathered a group of experienced, culturally competent therapists and psychiatrists who were willing to treat these patients in collaboration with Integrity Care Services, who would provide case management and other supportive services, including medication support services. These clients are all Medicaid enrollees who, really should be entitled to receive treatment at a OMH licensed mental health clinic instead of having to rely on Mr. Folman's model of fundraising, basically, to support the treatment. So for just taking the 50 that they're working with now, their efforts have been very successful. None of these people have been hospitalized within the past year. 38 are currently working competitively or attending school. And all but 3 are now compliant with treatment and medication. 15 of those people have submitted written responses to OMH, which we passed along to OMH, that document their inability to find adequate mental health services and their strong feeling about the services they've received at Integrity Care Services. So this proposed clinic is a specialty clinic in many ways. It serves a special, high-need, high-risk, cultural population, the Orthodox Jewish community, and including those with serious mental illness whose needs haven't been met by the current system. So, we have also included, many other data points about the need. The fact that Brooklyn has the largest population of any county in New York, and yet 23 counties have a higher clinic utilization rate per 100,000 by Medicaid enrollees. 8 out of 10 of the Brooklyn inpatient units have experienced the readmission rate that's higher than the statewide average. Borough Park, where the clinic would be located, has one of the highest rates of serious psychological distress that was surveyed by New York City Department of Health and Mental Health.
All right.
So, in summary, there's considerable numerical indication of need in the proposed service community of Borough Park, but Mr. Follman has found there is a pressing need for a new provider that can serve the human beings who are afraid to access certain providers or who have not been successfully treated by them. Our statistics for just the more than 40 individuals who Integrity is working with now help to change their lives. These are just the tip of the iceberg, and to deny the chance to bring these services to a larger group, would not be a good thing, and we therefore ask the committee to consider approval of this important project.
All right, so so obviously there were 50 people who it sounds like you've done good work with, and thank you very much.
Way more than 50. We just
those are people who are being served right now.
Whatever. Right. But again, the situation is, I understand it, and again, this is what I'm trying to get to the bottom of, is OMH has done its research. I believe the certified letters were sent out, and you were a part of that. And the clinics come back, and one, in fact, is opening a brand new clinic January 1st, 2018, which is right around the corner, that should be adding more annual capacity. And again, these 70% are bilingual, Yiddish speaking, et cetera, et cetera. They're on 18th Avenue. I'm not sure exactly geographically where that is, so I don't want to do. So the clinics around there are saying we don't have long wait lists and we can serve. And you're saying there are a whole bunch of people sitting there that aren't getting services. So I don't understand, what's the disconnect?
Well, I think Mr. Follman should speak.
That's exactly what I'm hoping to hear.
And I do want to apologize. I know it's a little late. I wonder if I can have a few minutes to talk about.
I'll give you 3 minutes.
3 minutes.
3 minutes, honestly, because I should.
Well, we would like, really a time similar to the other projects. I know we're the last.
Yeah, well, you've already gotten 15 since we sat down, which is a time similar to other projects. In fact, I've asked a very simple question, which it really is coming down to, is that there's a parent, and I'll say it again, and this is what we need to focus on, because it's, we have OMH saying we've got lots of clinics in the area, there are lots of Yiddish speaking, and I know that's not the only thing to be culturally competent. There are lots of Yiddish-speaking therapists that are there. Geographically, they're not too far away. They're saying they don't have a long wait list, and they have capacity. And in fact, we've increased capacities. And you're saying, wait a minute, I live in the community. This is not. They need more help, and it's not available. And now I'm going, well, all right. So that's the issue.
So I will answer that question. Firstly, I'm wondering strongly because I know we sent out these certified letters, and actually most of them did not get back to us. We did get them back through an OMH letter stating some things about them. But we personally, in our office, our staff made many, many, many phone calls over months. And this is going back years also as we were trying to place individuals. And all of these clinics had very long wait lists, or they were not available. Sometimes they would say, yes, yes, maybe, and do an intake, schlep around until they saw a psychiatrist and a psychologist forever. This is fact number one, where we called all the clinics, and according to what we spoke, we did some what they call secret shopper techniques, and all of that was, there are big waiting lists. Second of all, Integrity Care Services provides special case management and supportive services to patients that need that help. Meaning that the fact of the matter that these clinics say that they have space actually means that people are not turning to them. People are not interested in looking for treatment because they're either hiding or they're not, comfortable with these clinics or not, whatever it is. Because me, as someone in the community, I do know that I was approached over the years, I would say by now maybe with thousands of situations where people were not receiving adequate help. And unfortunately, and very sadly so, in our community, the rates of crises that require emergency personnel to come down to the scene, hospitalizations, suicide attempts, very sadly, bunch of completed suicides, too many completed suicides, a huge amount of substance abuse has been rampant in the community recently. We've had, just in the last week, the Hatzolah Ambulance Services, which you're probably very well aware of, which is the volunteer ambulance services in Orthodox communities, called us down together with all other practitioners, and they said that this is becoming such a big problem that they just can't handle it. And actually, during the second meeting, they invited us, ourselves, and said, we know everyone else, we trust you guys. We would like you to do and create such a program for us where there is a less need for emergencies, where people are taken care of initially, and then if, God forbid, there's a crisis, you can be of assistance to handle that. Another point which is very important, I've been working with this over many years. I've seen that doctors who I've worked with and I know about are filled to capacity with hundreds of clients in our community who are paying out of their pocket hundreds and thousands of dollars for treatment. I know myself that many clients have stopped going to treatment because they couldn't afford it. And, when I talk to people and I ask them, go to the clinics, the answer is, first of all, or I was there and I wasn't helped, or they had no space for me. And some people just don't, maybe I shouldn't say the rest.
Okay, up to you. All right.
So, just in summary, I am positive, as well as every community activist that can be contacted in our area, and even most of the laymen would affirm with 100% certainty that the community is very underserved in terms of mental health treatment and in terms of seriously mentally ill people in specific. And to deny that service is really, I do think that it's the responsibility of the Office of Mental Health to provide enough services and good services for the people in the community.
Do we have any, I saw the local government unit, which I assume is the New York City DOH, NMH, has given a negative recommendation. Did the community board, or boards, I'm not sure exactly how it splits up, weighed in on this? I don't see anything from them saying that, you may not have gone to them, but is there anything officially from the community board saying that they disagree, they think this would be a good service, or they agree, or any way, one thing or the other?
No, I mean, the community board is not involved in a PAR application usually for.
I understand. No, but the assertion is being made that the community really wants this and it would be a great thing, but the only proxy for the community, basically, that we're seeing is the OHMH, and they're saying, nah, we don't need it.
No,
so.
we did submit a letter of support from the Hatzolah Ambulance Services, We did submit a letter of support from the assemblyman who serves the district.
Okay.
And we did submit a bunch of letter supports from community members. We did not go out to the public and start saying that we're expecting a disapproval, as it would cause great uproar in the community. I hope that we won't have to go there next, but we have not done that yet.
Okay. Well, I don't necessarily pitchforks and the like down in the community chasing after us. No, but I'm just saying, okay, but that, I'm just, from my perspective, is we don't have a community board or a recognized entity like that who is weighed in. I'm just telling you what we're looking at and the like. Okay, members of the committee or council, any particular questions?
I would just ask, in terms of there's a disagreement about the need, and I would ask if you did anything more formal in terms of a needs study that could be used on your end to justify the need. I'm a housing developer. When we use the state funding to develop housing, we have to show that there's a need for it, and oftentimes we'll do an independent market study, somebody coming in. I think right now, there's a number of sources saying that there's not a need for it, and there's not a lot of hard evidence on your side that there is a need. So I'm asking, is there anything, or could there be something that you could come out with?
I mean, the fact that we are assisting hundreds of clients, I mean, now 50, because that's the maximum we could maybe work with if we stretch. But over the years, we've worked with hundreds, and I didn't count clients. That in itself is a very strong indicator of need.
Yeah, the fact that there's 50 clients that whose needs can't be served elsewhere, and so Mr. Folman and his group has successfully intervened and fashioned or designed a treatment system for them. And these are not worried well. These are seriously and persistently mentally ill clients, as I described previously. Many hospitalizations, many suicide attempts, and they have been successful. So these are, this is not a study, these are actual people.
I think we've relied on the existing work that's been done by this applicant. And it is into the thousands of people, 50 at a time, as we say. If the committee were to defer, I think, as Mr. Folman said, there was a goal of not creating a furor in the community over this. If we were to be deferred a cycle, I think we could go back and seek that type of community board, et cetera, type of input.
Because what I'm suggesting is, I mean, if we turn it down, and I mean, that's not the point. I mean, the point is not to have everyone explode and then go running around and having to go around the process or do something. I think that I mean, I'm looking at it as we seem to have a real disconnect, which is rare. Normally, we're pretty much on the same side. I mean, there's gray areas, like this happened the last one, like it's pretty, those beds. But this thing for you guys to say, wait a minute, I've been working for years there, and I'm providing services and trying to hook people up, and it isn't working. We need it, and we got OMH saying, what are you talking about? We got tons of it. We're bringing more on next month. This is silly. We don't need it. I think that if we do defer it, to allow OMH really to put it together, to allow you to put it together, and frankly, I mean, the service history that you're talking about and where those people ended up going or didn't going, and the like might be helpful, as well as if they're organized governmental type bodies like community boards and the like, of more than just testimonials. I mean, as much as I love testimonials, but at the end it's a series of testimonials. It doesn't really give you data. It might allow the committee to do a better, the committee to do a better job the next go around. So I'm inclined to go in that direction, but before we make it formal, I'm looking to see if the committee members think that's a reasonable approach. To defer it one cycle with a clear understanding, a recommendation to the full committee will be to defer it for one cycle to allow the applicant to put together a better, more comprehensive review of the services they have provided and where the need is based on the evidence they have, as well as to see if community organizations in Borough Park and the like can be rather specific in giving us the evidence and the data we need, allow OMH basically to do the same thing, and see whether or not it's just a mismatch, that there are lots of things available that you weren't aware of and weren't taking advantage of, or as you say, from a secret shopper point of view and the like, what they're telling us in certified letters doesn't match up with what goes on in reality, which has also been known to happen. So I think going that way makes some sense. Is if the committee just a straw poll, does that seem reasonable?
Yes.
All right, so now let's make it a real poll. So the motion will be whatever I just said, and whatever I remember to say in another hour. All those in favor, please say aye and raise your hands. Anyone opposed? Okay, so that's what our recommendation will be, and we'll see what happens in an hour or so.
Thank you so much.
Okay, all right. We are adjourned, I believe. There's no other business. Keith, we're good?
Yep, we're good.
All right, so we're adjourned, and I imagine Dr. Samuels would be happy to in a moment.
Let me call the meeting to order of the Behavioral Health Services Advisory Council. I'm Paul Samuels, the chair. Why don't we start with introductions in Rochester, please?
John Lee.
Jim Scordo.
Michael Martin. That's it.
And now in Albany?
Susan
Wheeler. Bill Getman.
William LaCates.
Kate Breslin.
Has everybody said hello there, including the guests or people from the agencies?
Certification.
Sherry Noonan, consultant to Ocean Recovery East.
John Krepsack, Ocean Recovery East.
Choices Recovery Center, Stuart Rosenblatt.
Michelle Woods, Oasis Certification.
Diane Gurdon, Oasis Certification.
Okay, thank you all. And now here in New York City.
Grant Mitchell.
Glenn Martin.
Lawrence Brown.
Patrice Wallace-Moore.
John Castan.
Ralph Fasano.
Okay, and then our guests and agency people, please introduce yourselves.
Braulio Guerrero, Urban Health Plan.
Shireen Case, Urban Health Plan. Pamela Timmons, consultant with Urban Health Plan. Urban Health Plan, Florida.
Rosa Gil, Community Live Inc.
Francisco, consultant.
Joel Walker, Integrity Care Services.
Okay, welcome. Before we start the formal agenda, just a couple items. First, I'd like to thank Susan, who is in Albany, Susan Orens, who's done such a terrific job providing the administrative support for the council. This is her last meeting officially doing so, so I would like to give her a huge, hearty round of applause. For the terrific job she has done. Thank you, Susan. I know that the support going forward, we'll have to do a good job to catch up to what you did. I'm sure they will, but we really appreciate everything you did.
Thank you.
Thank you.
And then secondly, while we're doing thank yous in this time of Thanksgiving and holidays, some of you may have noted my funkier tie than usual. This time of year, I think about people who I'm grateful for what they've done, including for our field. And one of them is always our dear late friend, Ira Marion, who many of you I know knew. Ira was one of the pioneers in the field of medication-assisted treatment for substance use disorders, and opioids. He was also one of the key people in bringing the alcohol and substance use fields together into one unified field, among many other accomplishments, and he was all around just a mensch in every way. So I put on a tie that I got from Ira, thinking about him today. So thanks to him, but also thanks to all of you for the terrific work that you all do every day. This is the season to do that kind of thinking and gratitude. So thanks to everybody here and all of
our colleagues out in the field doing the great work they do to help so many New Yorkers. So let's move on now to the business of the day. The first item is to approve the minutes of our September 13th meeting. Do I hear a motion to approve?
I'd like to make an amendment to it.
Sure.
On the, in the minutes of the section where it talks about Conifer Park and its vote, I abstain from that.
Yes, you certainly did abstain from that, I remember. So we will amend the minutes to reflect that. Thank you. Thank you, Patrice. Are there any other amendments or edits to the minutes? Okay, hearing none, do I hear a motion to approve?
So moved.
A second?
Second.
All in favor say aye.
Aye.
Any opposed? It passes. Okay, and now we go back to you, Patrice, for the Regulations Committee.
It's good afternoon, everyone. And we only had one regulation that we discussed today. I'm going to pass that on over because it's really more of a consensus recommendation. So, who's presenting?
Oh, I'll do it. This is Julie Rodak. This is a consensus regulation. It creates no new substantive provisions. Essentially, all it does is take one section of 14 New York CRR, Part 594, specifically 594.8. It just reorganizes the admission criteria for licensed children's housing programs. Initially written, I think, in 1993, there were 3 different types of housing programs: crisis residence, community residence, and teaching family homes. And then in 2009, these regulations were amended to add the credit programs, the eating disorder programs. And collateral damage of that effort was muddying of the waters. So when a simple question was asked, does the 90-day assessment, psych assessment requirement apply to crisis residences, we came up with a couple of different answers. And I think the answer that I think makes the most sense, and which everyone thinks makes the most sense, is no, because we don't want to limit access to a crisis residence. All we're doing in this particular effort is reorganizing 594.8 so that you can reach that answer more quickly. And that's it.
And so with that simple recommendation, the committee, we're not enough of us to really give a consensus to bring it forward, but we recommend that it be brought forward.
Okay, so so the committee motion is to approve?
To approve.
Is to approve, okay. Is there a second to the motion?
Second.
Okay, any discussion? Hearing none, all in favor say aye.
Aye.
Aye. Any opposed? Any abstentions? Passes unanimously. Thank you, Julie.
Thank you.
Is that, and that's it?
And that's it.
Okay, thank you. The next item on the agenda, the Project Review Committee. The esteemed Dr. Martin, goes to you.
Give me a moment. My device has been a little ornery this morning or afternoon. Making progress. Okay, let's start off with Oasis if we can. So we did have a quorum, so our recommendations represent actions of our committee. The first we talked about was Brooks Memorial Hospital, formed after a donation by the Brooks sisters over 120 years ago, that now wishes to change sponsor in order to remain viable, and basically will eventually merge in some shape, manner, or form. It is now with TLC Health Network out in Erie County. I'm surprised I can see anything in Erie County that doesn't mention Kalida, but I assume that's coming next. That's not an official committee statement. So basically, it's a change of sponsorship. It's been recommended by everyone, and we do too, so we recommend to the full committee approval of this action.
Okay, so the committee's recommendation is for approval. Is there a second?
Second.
Someone, okay. Dr. Brown. Are there any conflicts Or abstentions? Okay, any discussion? All in favor say aye.
Aye.
Any opposed? Any abstentions? Passes unanimously.
All right, next up is 2017.109. This is a new OASIS sponsor. This is Mental Health America of Dutchess County that wishes to become the sponsor of certified programs currently being operated by MARC, the Mid-Hudson Addiction Recovery Center. There are no changes to services, staffing, or anything else being proposed with this. It is a ownership type change, basically, or sponsorship change. Both of the organizations are in good stead with the governmental agencies that keep an eye on them. Fiscal viability appeared appropriate, and our recommendation is to approve.
Okay, so the committee recommendation is approval. Is there a second?
Second.
Are there any conflicts? Any discussion? All in favor say aye.
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 Any opposed? Any abstentions? Passes unanimously.
Next up is a capital project. This in Schenectady, and it's Alcoholism and Substance Abuse Council of Schenectady County, DBA New Choices Recovery Center. So apparently they've been operating out of a building, a 120-year-old former Masonic Lodge. I was really upset if a Masonic Lodge was falling down, but it turns out that it's the infrastructure inside of it that is not doing particularly well. I understand the Masonic temple is actually up on the 5th floor, currently not being used, but the Masons are going elsewhere to displace them. They'd like to move to a new facility at a considerable cost, as was delineated in the paperwork. DASNY is involved in the project, and basically it's felt that the old facility clearly is not up to what it needs to be for now. Renovation of that would be about $10 million. This is about $6 million, and will give people a better location for the services that are needed. Again, the agency is held in good repute. Fiscally, it looks appropriate. There's a little bit of this isn't the one, right? That's the other one. Okay. And they're in alliance with the district provider. Local government units are for it, and so are we. We have a recommendation for approval.
Okay, the committee recommends approval. Is there a second?
Second.
Are there any conflicts? Any discussion? All in favor say aye.
Aye.
Any opposed? Any abstentions? Passes unanimously.
Okay.
For Oasis?
No, and one more, and an add-on. This is 2017-073 Ocean Recovery East that wants to open up a new Part 822 outpatient chemical dependency treatment service and a medically supervised service provider. That's 816.7 for 18 beds in the city on the East 60th Street. So a lot of the discussion around this centered around the fact that this Ocean Recovery West is mainly in California based, and they said that they had noticed a significant number of clients flying out from the East Coast to receive treatment there. These are clients described as professionals, generally older and generally addicted to pills, who for one reason or another didn't want to get treated in New York City in the treatment facilities that were available to them. And there was a fair amount of blunt discussion about it because of the criminal history and other perhaps demographic characteristics of the people that they would be served with. So Ocean Recovery decided that there was a unmet market need here and that they would be able to meet the market, so they wanted to open up on 60th Street. We discussed with them that they were planning on making a decent amount of money. It was like $3 million a year net, I think they were suggesting in their proposal. maybe wrong about that. $4 million, $3.5. $3.5 million surplus is what they were projecting. So we did have a somewhat animated discussion about, that's all very nice that those people feel that they would prefer to be in New York and fly out to California, but there are a whole bunch of other New Yorkers who I imagine would also like to avail themselves of a bright new shiny treatment facility on East 60th Street that, since they're not going to be taking Medicaid, that whether or not they would be able to provide services there. And we ended up with a motion that basically, and we understand it's a little bit complicated because we don't necessarily have a mechanism or teeth behind it, but they have committed to do at least 10% or more of their beds, treatment slots, whatever, would be used for people who basically don't have insurance and would have to pay for it out of pocket. Some would be what the term of art apparently is scholarships. Others would be sliding fee. There was a brief discussion that it does, from a treatment modality, there is some evidence that having skin in the game makes some sense, so that you wouldn't necessarily want to give somebody it completely free, even if it's almost nominal that they have something involved. But the idea being that 100% of this would not just go to people who can easily pay for it or have insurance, but that 10% plus would be shared, would be saved for those who can. And we left it a little bit fuzzy about the 10% plus, because basically it was, we didn't want to wordsmith totally negotiated, nor frankly do we know that there are any teeth behind it anyway. But that was a recommendation we're bringing forward to the committee, that I think we're convinced that there is a need. They will probably be able to keep their beds filled, and they're willing to be offered to be good citizens in the regard of at least 10% would be for people who don't necessarily have the wherewithal just to walk in and pay for it. So that is our recommendation.
I have a question.
Please.
So, do they believe that building a program in New York is going to keep you going to California? Because with all the programs in New York, if somebody wants to go to California, they're going to go to California because California's beautiful. Right. So, like, I guess that was my question.
I believe the applicant asserted that they believe that those people who are flying over to California to get their services who meet that requirement of having money or insurance would no longer have to fly to California. They would be happy to be treated on the system. There was not a large amount of data supplied. We didn't ask for it, nor was data supplied to back up that assertion.
So did they didn't give you how many people have actually come to them from New York?
I don't think we asked. The Oasis may actually know that.
I'm sorry.
They may have come on.
The providers are.
Well, the providers I think are there. But that's, I leave that up to Paul whether or not he wants to talk.
Yeah, it's fine to ask that question if we don't know the answer.
I do know. We do know. I do know. I have 50% of my
Want to get closer so they can hear you? Just come here, then they can hear you better and see you, I think.
At least, I'm here frequently, but 50% of my clients, I have a different service. It's extended care, so they're step-downs from primary and or failed treatment, but at least 50% of my clients are from the tri-state area, mostly New York.
What is that raw number?
Yeah, what's the denominator?
The raw number. Because 50% could be 5.
What's the number like?
For my
50
year?
people? I don't know.
Oh, okay. Give me 30 seconds here.
Yeah.
I'm a small program, 34 beds, 100 people. Because I'm a 90-day program that's a year-long continuum, so I don't have a lot of admissions. This is a wholly other animal, and it is a very standalone operation. It is not in any way coordinated with Ocean Recovery in California. It really did appear to be a need for this service and the outpatient for reasonable detox services and an independent and a model for treatment, a treatment episode.
Especially
So the
keeping in
answer
mind
is
that
100?
we're talking
At
about
least.
detox, which is a very short stay.
Short stay.
Most people would rather be able to do it in New York than have to fly out to California for a 3 or 4 or 5 day treatment.
Yeah, well, we don't do detox. It's not a part of our continuum.
So is this program just a detox program?
Well, it's detox and intensive outpatient.
2 programs, please.
2.
Okay, 2 programs, okay. So it's an intensive outpatient, it's an outpatient and an inpatient as well.
Well, residential, yes.
Just detox and outpatient treatment, so that patients would have the ability to step down from the detox into the outpatient treatment.
Well, the model is an intervention model, and really prior to admission, this is the goal, is everyone will have a plan in place prior to admission. Well, all things being equal, we know that's not always possible, but it's very intensely driven for treatment episode to be managed.
And East on Jefferson Road. Okay, thank you.
Thank you.
Dr. Brown, did you have? Sorry. Dr. Brown, did you have a question?
I do. I've heard you mention the fact that it's a model, and you mentioned about having a treatment plan. I'm not sure that I understand how that is unique. If maybe you could share with us how this treatment plan is unique compared to treatment plans being on the landscape, understood as a part of professional guidelines. So what makes this a model?
I think she meant unique to each patient, not unique globally. I think you may have misunderstood.
No, very standard. So in terms of in the investment in the treatment episode in the patient.
The other question I have is that I heard Dr. Martin mention about that you're willing to be receptive to allow 10% of the slots of beds for persons who don't have the ability to pay. My question has to do with what about patients who have Medicaid? How are we addressing that population?
We don't. That is not
we're not
the population that we're treating.
Medicaid. There, as you all know, there's a lot of facilities in New York that accept Medicaid. There are not a lot of facilities that are primarily private insurance. So this is a different model. People who don't have the ability to pay, though, as is their current practice in California, they quite frequently scholarship and work out reduced fees for those patients.
Right.
And are willing to, we're planning on, before this discussion on their own, we're already planning to do that, so have no problem continuing to do that. We're committing to do that in this program, since it's their standard practice.
Well, let me just say, I do appreciate that. I really do. But, we cover the entirety of New York State. And our patients, in fact, are diverse in terms of their ability to pay, and not only with respect to whether they have private insurance or do not, but also with respect to Medicaid. So I guess I would be receptive to hearing whether or not this program is willing to, in fact, since it's willing to embrace patients who don't have the ability to pay, and since this is such a great model of intervention that we've heard about, why would we not make it available to persons who have Medicaid?
Again, as we said, there's an abundance of beds right now, detox beds available for individuals with Medicaid. The problem is that a lot of patients who are not on Medicaid are not comfortable in those treatment settings. We're trying to provide an alternative treatment setting for individuals to encourage them to come into treatment who may not be coming into treatment in New York right now and are in fact going to treatment in other states. So we feel like there are a lot of beds for folks on Medicaid, not a lot of beds for folks who are not on Medicaid. We know that the pill epidemic is strongly hitting folks who are not on Medicaid, and there's not a lot of resources to treat those folks right now. The vast majority of beds in the OASIS system, in fact, take Medicaid. This is
You do understand there's still substantial unmet need even among the patients who have Medicaid.
We do, but there's even less beds for people who don't have Medicaid. So we're only talking about a very small number of beds here. We're talking about 18 beds, which obviously is a drop in the bucket in face of the need across the state. We understand that. But we are certainly willing to take patients who don't have the ability to pay via the scholarship, just not via accepting Medicaid. They will have an alternative means to serve those folks.
John?
I guess I've got two questions. One is this distinction you're making that beds that serve in facilities that accept Medicaid are somehow off limits to people who don't have Medicaid. I think there's something off about that notion, Medicaid versus other. But I guess if you're not taking Medicaid, then I'm curious, what does the state certification give you that you couldn't have by operating in some other form or fashion without an OASIS certification?
You can't operate without an OASIS certification. It's required.
Well, you could operate this as a medical facility.
No, you cannot. You cannot operate a medically supervised withdrawal without an OASIS license. It's just kind of interesting to me that
from the council?
Go ahead. We're offering to expand treatment services without utilizing public funds in any way, shape, or form, which seems to be an issue. But Medicaid is state dollars and federal dollars. It's public resources. We're looking to expand treatment capacity without taking any resources.
Are there any other questions or comments from the council? Okay, so the motion from the committee is for approval with the understanding that at least 10% of the patients will be people who are unable to pay. Is there a second to that motion?
Second.
Okay. All in favor, say aye.
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 Any opposed? Okay, we have 2 opposed in New York. I can't see whether there are any in Albany. So the motion passes with 2 votes against. Okay.
All right. That concludes OASIS. We move on to OMH. The first one on the agenda, this is Integrity Care Services, MHD 2059, where we're recommending a deferral of 1 cycle. The situation is that the applicant asserts that there is a clear and pressing need for more services in the Borough Park community that are particularly sensitive to Yiddish-speaking, Orthodox, Jewish residents who have cultural and linguistic needs, and that despite being in the community providing what it sounds like a combination of case services of one sort or another, as well as referrals and treatment, their perception is that there are not adequate services in the community for this population. OMH asserts that there are lots of services in the community that are directed towards this population with lots of Yiddish-speaking and of culturally trained individuals, and that they don't have long wait lists, and that there's no need for anything else. I would say in my tenure on this committee, we rarely hear anything that is just so disparate. There's usually arguments around the edges, but it's rare that it's this wide. So I think the committee felt comfortable suggesting that the applicant do a better job of demonstrating the need. If indeed they have years of experience of doing this casework and have records and the like, they should be able to tell us how many people were being served, what the problem was getting them hooked up with services that appear to exist in the community, what experiences they've had in terms of referrals and linkages and the like, and at the same time allow OMH to reassess what their analysis of the situation. This may be a situation where the secret shopper type calls to clinics give different results and asking the clinic what your wait list is, or something along those lines. So we just felt that in the great disparate presentations given to us, that we didn't feel comfortable just accepting what OMH said and ignoring the rather compelling testimony of the applicant, nor do we want to take on face value what the applicant is saying, but OMH is saying, what are you talking about? What's going on? So we thought in this case, the pressing need could wait another month. I don't mean to be facetious, but it would just make sense to try to get a better fact base, and then we can make a decision. So that's our recommendation, is to kick it down the road another cycle with homework for both sides. So hopefully we'll have more information that we can agree on, and it will move. So that's our commitment's unanimous vote.
Okay, so the committee's recommendation is for deferral for the reasons Dr. Martin stated. Is there a second?
Second.
Are there any conflicts? Okay, is there any discussion?
May I ask on this one, it seems like, and I'm new to the process here a little bit, it seems the risk of over-serving this population is much smaller than the risk of underserving. And this was a facility that proposes to be 75% Medicaid and to care for indigent persons in a group of people who might otherwise not seek care. I think deferral sounds like a reasonable thing, but if there's persisting uncertainty, it would make sense to me, on the surface, to favor over-serving rather than underserving this population.
Yeah, I had the same thought. So I'm curious, kind of, I don't know if the department or somebody can talk about that.
Well, I mean, the committee did not speak extensively about it, but there's at least one other clinic that we gave approval to increasing dramatically their services as of January 1st. And, I'd let OMH discuss, but I mean, you run into the problem that you don't want to necessarily destabilize other clinics that are now staffing up to be able to do things by now ripping the heart out of what they expected to be. And I'm not saying that's the case, but you can make an economic argument that they were expecting these patients to come to them, and now we're basically saying, now we're going to let somebody else open there, so thanks very much for expanding. But it's not, you don't have the time. The population wouldn't necessarily be serving the public good either, but I'm saying this is all hypothetical because we really don't know exactly what's going on the ground, or at least that's our impression.
Stephanie, in kind of relation to that, we've had conversations about this a few times recently, but they were in regard to residential facilities. And from like a self-advocate perspective, we don't want to have an over-reliance on residential facilities, but we're talking about a clinic now. And to me, I'm like of the model of where the people want to spend their money is how a business survives. You want to be a business, that's you should have choice. And just because you have a Yiddish-speaking professional at your clinic doesn't mean that you're culturally what somebody's looking for. I wouldn't assume those things from what I see written here. So my thinking is, so if people decide to go to a different place and this other business was expecting those customers but didn't get them because their service didn't really appeal, then that's their loss, and that's not the consumer's loss. Is my opinion of that, because it's a lot different when you saturate with residential and higher levels of care than when you do with clinics, I think, personally.
Okay, thanks. Are there any other comments from the council or discussion? Okay. So again, restating it, the recommendation from the committee is for deferral for the next cycle, as explained by Dr. Martin, to look into the question of need from both sides in more detail. All in favor, say aye. Aye. Are there any opposed? Are there any abstentions? The motion for deferral passes unanimously.
Okay, thank you. The next.
Was there an abstention?
Yes.
Okay, I'm sorry. Thank you. There was one abstention in Rochester.
Okay, moving on to capital. This is a capital project involving a CPEP in Clifton Springs, MAH 2766. Let me just bring up the material. We recommended approval, just to take away the suspense. So this is a CPEP that clearly needs beefing up. In that they're basically they have beds upstairs in their inpatient unit for the EOB beds or the crisis beds. I can't even remember which one's there. They're located in the ED. They don't have a separate spot, and they don't have dedicated staff. They're sharing. It's not a particularly great deal. So essentially, they're going to put some money in it and take care of the physical plant stuff, so they can put everything in a one ER area contiguous with the medical emergency room. They've had some staffing issues, and in fact, they will not have a full-time psychiatrist on staff there. They will be using telepsychiatry, and they will be coordinating with another somewhat crisis-y, urgent-y clinic that they have closer to Rochester. So it sounds like the provider is going to try to take advantage of the services they do have, use telepsychiatry to beef up what they don't have, and allow a CPEP to continue to survive and in better shape in an area of the state which is certainly not overserved. This is about an hour, maybe a little less, southeast of Rochester. South of Palmyra. So our recommendation was to approve.
Okay, the committee's recommendation is approval. Is there a second?
Second.
Any conflicts? Any discussion? All in favor say aye.
Aye.
Any opposed? Any abstentions? Passes unanimously.
Okay. Next up is Erie County. So they need to spruce up their CPAP. I think it sounds like they've got waiting rooms that are a little bit too large. They need to be made smaller. They need a new exam room. They need to make it a little bit less noisy in the adolescent area. They need to take care of medical students and reconfigure and do a bunch of stuff. All of which sounded reasonable, and we recommended approval.
Okay, the committee's recommendation is for approval. Is there a second?
Second.
Any conflicts? Any discussion?
I have a comment. Just because I know that ECMC has adolescent peer advocates, I would really like to recommend to them to include youth peers in some of these redesigns, especially for the waiting room, and make sure they get youth input in that.
Sorry.
Oh, sorry. Yeah, no, there's like a white noise. It's like we're in a air filter or something. I know ECMC utilizes youth peer advocates, and I'd really like to see them bring in youth input as they're doing it. It's not like going to change my vote either way. It's just more of a recommendation for a process, since they have them.
So is that something that we can add to our, as we vote?
Because I know we can't require input from people because it's not in but I would, just like we recommend it with taking Medicaid, I think it should be one of our practices to have self-advocates give input to projects like these.
You guys are the council.
Awesome. Cool.
Okay, are there any other comments or discussion? Let's go to a vote then. All in favor say aye.
Aye.
Any opposed? Any abstentions? Passes unanimously.
All right. Next up is Finger Lakes Area Counseling and Recovery Agency, otherwise known as FLACRA, wants to take over a aptly named Interim Healthcare of Rochester clinic treatment program that is getting out of the business. And FLACRA will be, with our committee's recommendation and the commissioner's approval, transfer over to FLACRA. FLACRA is been in business for a while, is well reputed, et cetera, et cetera. And the recommendation of our committee to the council is approval.
Okay, the committee recommends approval. Is there a second?
Second.
Are there any conflicts? Any discussion? All in favor say aye.
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 Any opposed? Any abstentions? Passes unanimously.
Okay, next up is one more bite at the apple of Brooks Memorial Hospital. And this again is the same change in sponsorship and new arrangement with TLC Health Network. It's been in existence since 1898 when the Brooks sisters gave their mansion over. And apparently, and I don't remember why, is that they're also at FHUCB, they're going to plan on making a lot more money than Brooks than they were before with it. But in any event, it's basically keeping the same program, making it more financially viable, being run by a group who's been demonstrated a track record of being able to run things like this. This has received, as we just said, positive authorization on the OASIS side. FIPIC is in the middle of approving it, or likely to approve it, and now this is the O of HP, so we recommended approval.
Okay, so the committee's recommendation is approval. Is there a second?
Second.
Any conflicts? Any discussion? All in favor say aye.
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 Any opposed? Any abstentions? Passes unanimously.
All right, next up is SUNY Upstate. And they actually want to increase beds by establishing an 8-patient inpatient, an 8-bed inpatient psych unit for adolescents, which is actually rare that this committee ever gets to vote to increase bedding for adolescents. In addition to their 24-bed unit, Upstate is the big provider in that area. There are testimony about long wait lists, et cetera, as one would expect. There are kids stuck in their children's hospital for ridiculous periods of time waiting for placement in psychiatric facilities. It's a standard story that we know, but they're willing to step up and take care of this unit. I asked a little bit about how they're going to be integrating residents and medical students there, figuring that it would be a teaching opportunity. Like I assume they have a child fellowship in their department. Didn't get a clear answer to that. That's basically the proposal, and adding beds in an area that seems to have demonstrated need made sense to us. So we have approved it and recommend unanimously approval by the committee at this time.
Okay, the committee's recommendation is approval. Is there a second?
Second.
Are there any conflicts? Any discussion?
I have a question.
Go ahead.
Is there any surprise? I was surprised, and I wonder if you had any discussion about that there's no psychiatrist listed in the staffing?
I don't think that's accurate because I would have. Well, it says physician. It does say physician. We are physicians. I guess I sort of read that to be the appropriate specialist physician, but you're right.
They did confirm.
But they said it was going to be a child psychiatrist. They said it would be board and psychiatrist.
Okay.
So, because maybe I'm missing it too, the specialty in children's services and the staffing patterns, did they discuss that? And
well, it was a child psychiatrist. I don't think we got down furthermore into the training that the individual social workers or LPNs and the like would get. I mean, understanding that they've got to be appropriately trained just under JACO and other regs as well as here. Did not specifically ask about the psychologist and art therapist, but clearly we can make some statement of the fact that they would be appropriately, have appropriate expertise in the treatment of that age group.
I think it's also the direct care staff, because often you'll see in facilities like this where it's on multiple floors, staff move between floors and don't necessarily know the differences in the children's world versus adult in terms of treatment and regulation.
Well, that would not be a good thing.
Right. It's not a good thing, but in terms of quality assurance, it happens.
I can do is assure you that they're properly staffed, trained, and credentialed. I'd have to go back through the application to pull specific information.
But we don't have an expectation in New York State that somebody has specific training in child to.
No,
they have to
I think
be
that
a
as we review
boarded-
an application for a given unit, we review it to make sure that they are properly trained and staffed to do what they're proposing to do, regardless of whether it's listed out in regulation that they have to have this, have to have that.
No, and certainly in previous discussions, we've honed in, as you said, Jennifer's certainly good at pointing us in that direction, honed in on the staffing and the like. Once they mentioned the child psychiatrist, I have to admit, I stopped thinking about the rest, but I agree with you that clearly the psychologist, the art therapist, the recreation therapist need to be appropriately trained in that area, as well as the LPNs and the like, and everyone there. So, I mean,
I think the other part of it is we've got kids backed up in these facilities that are not being treated well, and this is, it's only 8
Absolutely.
beds. It's only 8 beds. It's a step forward. So I give them credit for expanding with a tough population.
And I also, as a positive, will say I like the small, more scattered facilities. It's a good direction to be going in.
And the way it was presented is that this is sort of a interim between, coming in for a CPEP versus a long stay option.
Yeah, I think it's a great idea. I just want to ensure that we think about quality, and because often with just a small amount of beds and a larger amount in the adult, you will see that where they're going to pull staff, and it's more on the back end of watching how things actually get implemented, but it's a concern.
All right, is there any other discussion? Let's move to a vote then. The committee recommendation is for approval. All in favor say aye.
Aye.
Aye. Any opposed? Any abstentions? Passes unanimously.
Okay. Next up is also a capital project. This is Northern Rivers Family Services and Parkland Child and Family Center looking to rebuild an existing residential treatment facility in new construction with space for 2 future programs that would make sense to have, but they are not part of this application at this time. They reported that agrees that this is part of our community needs identified from the survey involving districts. And it felt that it is still required. Northern Rivers Family Services is currently in good standing. There are no changes to anything being contemplated in terms of staffing or capacity. Decent amount of money comes from the district money, and the decent amount of money will be coming from Northern Rivers. A little bit confusion in the numbers because we didn't exactly see. I mean, there's a line for rent, but there wasn't like a line for mortgage. We didn't exactly see where money was sort of flowing, but we were assured by OMH that fiscal viability was looked at, and they believe that this is a viable project. So with that assurance, we agree and recommend approval.
Committee recommendation is approval. Is there a second?
Second.
Any conflicts?
I have one.
Go ahead.
I'm the CEO of Northern Rivers. I have a conflict.
Oh, okay.
This is mine.
All right, thank you. Is there any discussion? All in favor say aye.
Aye.
Aye. Any opposed? Any additional abstentions other than the one we already have? Passes unanimously with 1 abstention.
Okay, next up is in the Bronx. This is a request from Urban Health Plan to take over the operation of 2 existing clinic treatment programs of Community Life, the VITA Guidance Center, as well as the VITA Guidance Center at St. Vincent de Paul Satellite, one on Interval and one on 3rd Avenue. And otherwise, they will continue to serve children, adolescents, and adults. Took us a moment or two for me to figure out what was going on, because Community Life is not going out of business. they're a big provider up there and well reputed. And Urban Health Plan will be taking over. Urban Health Plan, however, has the advantage of being an FQHC and will be able to take advantage of that in terms of billing, that they now believe they can turn two clinics that are not really fiscally viable into, voila, they're now fiscally viable. It's an amazing system we work with. And will also allow probably for better integration, quite frankly, of primary care services and the like. So not only will they be able to make some money doing it, but will be able to provide probably better service in an integrated way to the community. So it looks like a bit of a win-win. I actually asked the applicant to hang out only because, just to make sure staffing, if Jennifer had any questions about it. There are two psychiatrists listed for this program. One of them is a boarded child psychiatrist. That position apparently emptied and filled.
Actually, we'd like to clarify.
That's all right. We have
the psychiatrist who is staying on with Urban Health Plan is a child and adolescent psychiatrist. It is the other psychiatrist.
All right. So we have at least one child and adolescent psychiatrist employed who will remain that way, and another slot that will be filled, but will probably not be child and adolescent because the program is still a mixed program, and it sounded like a little bit less than half for kid. Yeah. So that kind of made sense. And again, there are various different licensed mental health social workers and the like who are part of the treatment team, as well as some non-clinical people there. We thought that we recommended for approval, and again, I had asked them to hang out just in case Jennifer had any particular questions about the staffing. But this is staffing that's similar to what goes on now. There's no reduction in staffing and how it's been operating with full certification during this time. So I presume it will continue.
So the committee recommends approval. Is there a second? Second. Are there any conflicts? Is there any discussion? All in favor say aye.
Aye.
Aye. Any opposed? Any abstentions? Passes unanimously.
Okay. We move on then to Woodhull. So Woodhull would like to close 23 beds that they're not using anyway. Then they're going to basically change their CPAP, move it around, put it together, and make it a better unit than it is now. The unit, as I said, they're closing beds that have been occupied in over a year, and will go down from 135 down to 112, and then it will allow them to have the space and means to improve their CPAP. So again, this made sense, and we recommend approval.
Okay, the committee recommends approval. Is there a second?
Second.
Any conflicts? Any discussion? All in favor say aye.
Aye.
Aye. Any opposed? Any abstentions? Passes unanimously.
All right, and the final project for today is on Staten Island, and this one apparently made much more sense to the committee than to me.
Good thing you have a committee.
Yeah, absolutely. Yeah, but I get to make the report, so I get to say it anyway. So basically, Staten Island, as you know, there's a lot of movement in Staten Island, and there have been some changes in programs and the like, and bed size with downsizing, and OMH took a deep breath and realized that both Richmond Medical Center, or Richmond University Medical Center, as they're known, as well as Staten Island University Hospital, were all busily closing and opening and doing things simultaneously, and we wanted to make sure that it was somewhat coordinated. So this is sort of the Richmond University Medical Center part, and they tell us that Bailey Seton had 25 beds, I believe, and the proposal was to close those 25 beds and move the 10 of those 25 over to Rumsey, the Richmond University Medical Center. The issue that I raised was those 25 beds have basically been taken offline already. They have done it on their own. They've reduced it to 0, and they've done this without having apparently exploded the system. They are operating at full capacity upstairs, but they don't have people waiting in their CPAP or emergency room. There has not been major disruption to services that we understand on Staten Island. So the question was raised, the discussion was around, so why are we approving you to move 10 beds if it doesn't appear you need them at all? There was the discussion centered around the fact that it's still very, very difficult to get people out of inpatient units into state hospitals for people who don't recover quickly and do require an extended care, and the projection is that will only get harder. The population of Staten Island very well may continue to increase, and the degree of substance abuse and other issues in Staten Island may increase the number of patients who do require the services. So after that discussion, there was a non-unanimous vote. I voted in the negative, everyone else voted in the positive, to recommend approval of this, which is basically to acknowledge the fact that the 25 beds have essentially been taken out of service anyway, and to give them authorization to build the 10 new beds at the main campus, but will be open in spring of 2019 is the plan. So the recommendation of the committee after that, of the committee after the discussion to the full council is to approve the project.
Okay, so the recommendation from the committee is to approve. Is there a second?
Second.
Are there any conflicts? Any discussion? All in favor say aye.
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 Any opposed? You have one opposed in New York. I don't see any opposed anywhere else. Is there? Sorry? Okay, so no opposed anywhere else. Are there any abstentions? Okay, it passes with one no vote.
Okay, and I believe that concludes the business of our committee.
Thanks again to Dr. Martin and the whole committee for your great work.
Thank you.
We now move on to Dr. Brown and the Workforce Committee report.
Thank you, Mr. Chair, and I'd like to thank the fantastic committee, Workforce Committee, because I believe that we are the best committee. And
that's good. We won't vote on that today.
A good thing, because we didn't want to embarrass the other committee. So, without further ado, we have a very brief report to let you know that the committee put together a group of about 16 questions that we're going to pose to both OASIS and OMH, and we're going to categorize them between those that deal with recruitment of the workforce, those that deal with retention, and we hope that between now and the next meeting of the council that we will have at least a couple of conference calls with OASIS and OMH to respond to these 16 questions.
Terrific. Okay.
And that's all I have to present showing why we are the best committee.
And are there any questions or comments? Not about whether it's the best committee, but about the report of the committee chair?
That was the best
committee chair.
It was the best report. I'll give him that. That I can see.
Will you share the 16 questions with us?
No question about it. We will send that out. In fact, we do have to thank Susan also, because she was instrumental in helping to orchestrate the committee to come together and have great meetings, and they were quite robust, even though they might have been brief.
Okay. Any other questions or discussion?
Are you aware of the in this was workforce? We had a meeting the other day about this NASW, the legislation that's coming forth and how that might impact the workforce and all that kind of stuff. So that might be something we might want to take a look at going forward. Because I know that that's supposed to sunset in 2018.
Get the exemption from the licensing.
Well, we may very well call upon the Department of Education to help us during these deliberations, because really they are a major stakeholder in this issue about workforce.
Absolutely. Okay, great idea. John?
No, I was just saying the other is the National Council for Behavioral Health, and you may have seen it, did a really good report on psychiatric workforce that looked at it nationally, but also I can share that with you if you don't have it.
I do have that. You shared it with me. In fact, that probably is one of that report gives you some sense about why there is a challenge with getting child psychiatrists, quite frankly. That's what we have.
Okay, any other discussion, questions? Thank you very much, Dr. Brown, for what may have been the best report, certainly was the shortest. Or maybe not, actually, I think Patrice still won on that.
Well, she's on our committee. There's a conflict.
Okay. Is there any public comment? Has anyone signed up for public comment? Okay. Is there any new business? Okay, well, I have the last word and the last new business, which is to wish everyone a very happy new year, happy holidays to everybody, and we will see you all in the new year. Okay? We are adjourned. Thank you all very much.
Thank you.